Yeah.
Amit, you start.
Good evening, everybody. Welcome to the scientific webinar and installation ceremony of ISMSICS MP chapter. We are going to start with our scientific program, that is the video bouquet of SICS. For that, I welcome all of y'all. This is going to be a scientific program of videos of SICS. Each video will be of 5 minutes, followed by discussion. So, to begin with, I welcome Dr. Purendra Basin to introduce all our panelists who are there for this webinar. Over to you, Dr. Purendra Basin.
Thank you, Dr. Amit, our dynamic scientific committee chairman. Welcome, Dr. Amul Sahu, sir, Dr. Boramani, Dr. Devashish Bhattacharya, and all the eminent persons from all over the country and world over who have made this as ISMSICS very international and very useful podium for all of us. It's really a wonderful day for everybody that we are going to have our webinar on scientific webinar and installation ceremony on ISMSICS MP chapter. I'm really delighted because I feel when I was at Arvind way back in 93, 94, I used to feel that any surgery is like this bird having her food, how nicely, how precisely she takes the food out, she does her work. This is the picture which I have taken it. This is a sunbird, purple sunbird, which without damaging the surrounding structures, with such a beautiful, such a small opening, like our manual small incision cataract surgery, we can perform our surgery and go ahead and give the good results to all our patients from various strata of the society. This bouquet of the scientific program, which incorporates all variety of cases and will definitely imbibe the confidence in amongst all of us and all the surgeons to do it. And I really know that SICS, manual small incision cataract surgery, has been in place since last 30 years. Since 1990, it is there, and we all know that it's a step forwards towards the phacoemulsification. What I feel is all our DNB students, PGs, they learn first the small incision cataract surgery, then they enter into, and we allow them to go into and do the phacoemulsification, because this is much more controlled as compared to the phacoemulsification. We have with us the panelist, Dr. Satish Premchandani, who is a dynamic, a very hard-working person from Indore. He is the director of Vision Center and is a very good phaco, refractive and small incision cataract surgery surgeon. Dr. Parikshit Gokte is from Miraj, and he has done his MS from Miraj. FRC is from Edinburgh and has secured 55th All India rank in civil services, and he has been trained in for the IPS also. This is really very remarkable feather in his career. He is presently a private practitioner, trustee of Community Eye Care Foundation, and a faculty at DY Medical College, Pune, Pimpri, and medical director of Netralaya. And he is the incoming president of Maharashtra Ophthalmology Society, and is secretary of International Society of Geographic and Epidemiological Ophthalmology, and the secretary former secretary of International Society of Manual Small Incision Cataract Surgeons. He has 90 papers in peer-reviewed journals with interest in cataract surgery, community ophthalmology, health, pediatric ophthalmology, and he has a special interest in training and research. Welcome, Dr. Parikshit. Dr. Sumatri is from Indonesia. He is working with the center in Indonesia, National Center for Eye Health, Sisendo Eye Hospital, Indonesia. Graduated as Master Science in Community Eye Health from London School of Hygiene and Tropical Medicine. Performed MSc manual small incision cataract surgery since 2008 until today. Had been doing this surgery and for more than 4,000 eyes. Teaching residency training of Ophthalmology Department, as CBM Medical Advisor from 2005 to 2014, member of Indonesian Ophthalmological Society, and has done various research work on various subjects in ophthalmology. Welcome, Dr. Sumatri. And we have Dr. Satanshu Mathur, who is again an eminent teacher and speaker at various podiums all over the country. He is the Chief National Coordinator of International Society of Manual Small Incision Cataract Surgery, Secretary of North Zone Ophthalmologic Society and Uttarakhand Ophthalmic Society, Chairman Scientific Equine, Joint Secretary FBS AIOS, Executive Member of IIRSI, and State Representative of AIOS. Dr. Sudhir Mashabde is from Indore. He is going to be the panelist again in this program, and he is the Vice President of this Society of MP chapter. He is a Medical Director Indore Eye Hospital and Director of Ophthalmology Index Medical College Indore. Dr. Srinivas Joshi is again a very bright star in the field in the ophthalmology. He has been elected as a member of AIOS ARC South Zone, National Secretary of our of this ISMSICS ICS. He has completed fellowship in vitreoretina at University of Toronto, North America, and elective fellowship in VR under Dr. Steve Charles at CRI Memphis, USA. He is the first Indian to be trained for artificial retina transplantation surgery and is a principal investigator for various anti-VEGF trials in India and abroad, reviewer of various international and national journals including AJO, APJO, IJO, etc. Received several Best Surgical Video Awards, including Red Buckler Award by American Society of Retina Specialists. I welcome you, and he has got the International Hero of India Award by AOS in 2018, 2019, and 2020. He is a very dynamic and very special, super person with a lot of energy. Welcome you, Dr. Srinivas. And with this, I thank you, and I hand over the mic to Dr. Porwal to continue the scientific program.
Thank you, Dr. Basim. So we have esteemed panelists which are national and international. So with these esteemed panelists, we start our scientific session. Our first speaker is Dr. U.S. Tiwari. He is a professor and head of GR Medical College, Gwalior. He is the most favorite and the most wanted teacher by all his students in Gwalior. I know him personally. He's the most loved teacher over there. He encourages all his students to be a great academician and to have a scientific and logical thinking. So over to you, Dr. U.S. Tiwari, for your presentation. So he's going to talk on step-by-step SICS. So we all know that SICS is the beginning, as Dr. Basim told, is the stepping stone in to learn cataract surgery. And you can't master anything without knowing SICS. SICS is a savior even in most complicated cases. And SICS is the basic surgery which every ophthalmic surgeon should know. So over to you, Dr. Tiwari, for SICS step-by-step.
Thank you, Dr. Amit. At the outset, I must thank all the office bearers of the ISMSICS. To name a few, maybe not be very justified, but I would like to make a special mention of Dr. Debashish, Dr. Amulya, Dr. Satanshu, Dr. Bhokte, Dr. Srinivas Joshi, and I may be pardoned if I miss some names. And it starts from abroad, Dr. Sumarti and Dr. Rahman from Bangladesh, Dr. Sumarti from Indonesia, and our own Dr. Amit, Dr. Purendra Basin, Dr. Meeta Joshi, Dr. Sudhir Mahashadde, Dr. Satish Premchandani, and my dear friends. Thanks for having me here to speak on the step-by-step SICS. Now I'll straight away move on to the video. Now, after having made this side port, I inject the air bubble and then inject the dye under air bubble to extend the anterior capsule.
Dr. Tiwari, you need to share your screen.
Oh.
You haven't shared your screen, yeah.
Is it there?
No, your share screen is not visible. Please share the screen.
Is it? No.
No. Do you want me to do it for you?
No. Is
Yeah.
it
Yeah.
now?
Now it
You
has
are sharing
started.
the
Yeah.
Now it
screen.
is here.
Now it has
Is
started.
it there?
Yeah,
So
we
you can
can see
start.
now.
It's there. Okay.
You can start from the beginning.
Okay, dear. Is it there?
Yeah. Visible.
Fine. So side port, then under the air bubble to extend the entire capsule. Now this is followed by a wash of the entire chamber, wash of any dye, and this is followed by injection of the visco to tighten the globe. Now that makes the further job easier. You can do your axis using a 60 tone, or you may use a Utrata, depends on your choice. Try to work on the everted edge of the anterior capsular flap. Since it is stand, the job becomes very easy. Try to make a larger axis, and even as a beginner, even if it runs off, don't worry, you can still do your SICS. This certainly gives you an opportunity to learn CCC. Now, if you feel like you may take a Utrata, because Utrata can give you a better control, that is what I personally feel. Now you complete the axis and then initiate the incision. Now, conjugal flap is made, a phonics based one, minimal cautery, initiate your frown incision, followed by dissection of the tunnel, dissection forward. Make sure that the edge of the crescent blade is visible throughout so that you are at a proper plane. Dissect forward, tunneling forward. Is that okay,
Yeah.
Dr. Amit?
Perfect.
Yeah, good. Then I enter using a 2.8 keratome, do a sideways dissection to open the globe to the required size. This internal corneal incision is usually about 6.5 millimeters, as you can see here. This is followed by hydrodissection. Now, make sure that the tip of the cannula goes at least 2 millimeters under the anterior capsule. Press the nucleus so that there is no fluid entrapment. Do at other places also, and try to prolapse one pole of the nucleus, as you can see here. Now, once a pole of the nucleus is prolapsed, you inject visco under this prolapsed pole of the nucleus and then wheel it out of the bag. Now, once you wheel it out, make sure that there is enough visco so that the posterior capsule falls back and you are quite safe. And then you can choose any preferred method. I demonstrate here the visco expression. Now just press this curly lip and in a visco filled anterior chamber. I repeat, visco filled anterior chamber. I can use this essentially and assist the delivery of the nucleus in case this is quite a hard one, as in this particular case. Now this is followed by cortical cleanup. Maybe some of this cortex can easily be washed out using a Simbo. You can use a bimanual technique also. Simbo go through the side port that gives you a fairly stable and a deep anterior chamber, and you can do the job very easily and confidently. Inflate the capsular bag as shown here. Once the capsular bag is inflated, you can very conveniently implant a rigid IOL or maybe a premium IOL, as with the subsequent speakers will be talking about, I'm sure. And then you can dial it in the bed. Make sure that it is in the bed by checking it. This is the anterior capsule. Yes, it is in the bed. And then you can wash the remaining visco and then stromal hydration. Use stromal hydration as shown here, and this is followed by injection gentamicin antibiotic injection. Thank you. Thank you, dear friends.
Thank you, Dr. Tiwari. It was a very nice presentation. The video quality was good. Now coming to the panelist, Dr. Basin, I will ask the same question to all the panelists. What would be the one important point which you would like to emphasize on to your students when you want to start him learning SICS? One important point or one important step of SICS which you would like to emphasize on to your students when they are beginning SICS. Dr. Basin.
Making of the scleral tunnel, that is an art.
So
If it is not properly made, then you are in trouble after that. All the steps you will have problems.
So you will emphasize more on a scleral tunnel.
No, not it is, but it is the first step.
Yeah. So any important tip you would like to give when you are making a scleral tunnel to the residents?
It should be at the proper plane. You should work at a proper plane. You should not push as I have shown my video of my bird, you have to work without damaging the surrounding structure. You should not damage the cornea. You should not puncture the cornea inadvertently early. So this is what the scleral tunnel is, the first and foremost and most important thing. And we have to be very, very gentle and careful without damaging because that can lead to damage to the Descemet's membrane. It can damage if early premature entry is there, the iris and everything will start coming out at each and every step, and you will have a lot of problem and issues. And chances of vitreous prolapse and many other things can happen. All the complications.
Okay, thank you. Dr. Premchandani, what would be your ideal tip to your residents when they are starting SICS? Which particular step you would like to emphasize on? Dr. Premchandani? Is he here? Is he there?
Yeah, Amit.
Yeah.
Initially, when we started doing small incision cataract surgery, there used to be one knife with a point at 300 micron. And we had to give a scratch incision at the sclera. So what Dr. Basin was telling was very correct, that you don't have to dip directly inside. Otherwise, you will start damaging the iris and the iris will start coming out. And secondly, that usually used to prevent the Descemet's membrane detachment. Okay. So if that knife is still available, I think residents can start with that.
Okay. Dr. Tiwari, can you please stop the screen sharing, please?
Stop?
No, you have not stopped yet. Yeah, now it is stopped.
Thank you, sir.
So, Dr. Sivamarthi,
I agree with a small comment. I agree with Dr. Basin about the tunnel making.
Just 1 minute. We'll take the opinion of all the panelists. Dr. Sivamarthi, what would you advise your residents when they are going to start with SICS? Which particular step is important for you?
Yes, the first step is you are right that just now the tunnel is very, very important, because if the tunnel is not properly, and then the residents training will get many problems after that. And after the tunnel and then CCC. When I saw just now, the CCC is not quite wide. It's not enough wide for the beginner. And also for the tunnel, I didn't see that it's you have to sew it a little bit properly and slowly for the tunnel. I don't allow my residents to move from one step to another step before they can do the tunnel very properly, because many problems will come after if they couldn't make the tunnel properly. Thank you.
Dr. Mashavdi, what is the first step that you will allow your residents to do when you are going to teach them SICS? You have to unmute yourself. You have to unmute. Dr. Mashavdi, you have to unmute. Okay, till Dr. Mashavdi unmutes. Dr. Parikshit, how would you start SICS training to your residents? You have to unmute and speak, please.
So when we have to do, there are two ways to do it. Of course, the first way, which is the traditional way, is that you teach how to make a groove and how to make the tunnel, because making the tunnel is the most important step. I mean, if you can do a good tunnel, you've practically done the surgery. Another is, which is not very popular, is a reverse method of teaching the surgery. So your that is
your voice is echoing.
So just now, is it better, sir?
Yeah.
Yeah, the other method is the reverse method of doing the surgery. In the reverse method, we teach the last step first. So the whoever is the mentor or the trainer does the entire surgery and just lets the trainee put in the PCIOL. That's would be the last step. Or perhaps would just let him clean the visco after the lens has been put. Then he does putting in the lens, cleaning the visco. So he goes step backwards, and the tunnel, which is perhaps the most important and the trickier step, is the step that the trainee learns last. So while this has been propagated a lot in teaching phacoemulsification, and we have publications on this, it has never been seriously tried in manual small incision cataract surgery. So mostly all over India and all over the world, wherever SICS is done, it is the tunnel which is taught first, which is also perhaps the most difficult step to master in the end.
I think we also do the same thing. We go the reverse way when we teach our residents from blast to the beginning, so that the resident becomes confident with his microscope orientation, with his instrumentation, and the delicate step which is tunnel construction he is taught the last. So moving with the next presentation. Thank you, panelists. We'll go with the next presentation and we'll get back to you for the next questions. So our next speaker is Dr. Devashish Bhattacharya. He doesn't need any introduction. We all know Dr. Devashish Bhattacharya. He is the founder chairman of Disha Eye Hospitals, Barakpur in West Bengal. He has served as the president of All India Ophthalmological Society and has previously served as an editor proceedings of AIS for 2 terms and also as chairman of Ethics Committee of All India Ophthalmological Society. He has performed live surgeries in various national and international forums, has got various presentations and publications in various index journals. So Dr. Devashish is his hospital provides one of the hospital. They do a high volume cataract surgery and the high volume is of SICS surgery. Am I right, Dr. Devashish? I think after Chitrakoot and Arvind, you are also at par with them in doing high volume manual small incision cataract surgery. And that's a matter of proud for all our ISMSICS members that you have kept this technology alive and are still keeping alive. So over to you, Dr. Devashish, for your presentation on M6 in supra-hard cataract.
Right. Thank you, Amit, for the generous introduction. Can I have my slide share, please? Yeah. So, this one. So I have been, I chose the topic that safe SICS in suprahard cataracts because this is a situation where even, the best phaco surgeons would feel that probably the day one look would be better, or probably the corneas will look better, the patients would be more happy. So I would take up this part. Essentially, can we go to the next slide? The video, can we have the video on? Yeah. So the most important part of doing a suprahard cataract would be to prolapse the nucleus out of the bag. The basic trick is, as is shown, that you have to get the equator out of the rexis and then walk on the equator, and you need to have a big rexis. So, prolapsing the nucleus and also the hydrodissection, we need to be careful because in most of these grade 6 black cataracts, you actually have the whole bag full of the cataracts. So minimal or, small hydrodissections have to be done just to free out the nucleus. Can we have the second video, please? Yeah. Now I show you a full surgery. I mean, if you are, the other way of doing, can we go ahead? If you are having problems with doing a big rexis, then the other thing is an envelope capsulotomy. You can also see, the way the scleral tunnels, as we were discussing, and the corneal valves being constructed. It should be uniplanar, and then the internal incision, which should not cross the limbus so that the watertight. And here, with the keratome itself, you can make an incision and enlarge it on either sides with a Vannas scissors, and this gives you an envelope capsulotomy. So these are good because they're effective, and you can actually just simply nudge the nucleus out of the bag. The incision on the lens doesn't come in the way, and then you can bring out the nucleus. So essentially, this is one of the good ways of doing. And at the end of it, actually, you can either fill the chamber with viscoelastics, or if you are, you can also plug it on with this. So this is a good way of doing supra-hard cataracts. Now, the main part is to give a big incision, because you need, and we will dwell on this incision part. The scleral incision has to be big, like about a 6.57 now, and then it has to be half thickness, because the scleral incision takes us to the scleral tunnel, and the wriggling forward with the heel down portion of the splitter is very important. Here, please understand, we will also clarify later that we are going and taking the corneal tunnel down to 3 o'clock and 9 o'clock. I mean, because it is a very hard nucleus that we anticipate. So essentially the internal incision, because the nucleus can get stuck in three portions. It can get stuck at the internal incision, in the wound itself, or in the external incision. So all have to be adequately sized and yet be self-sealing. Now, please see that, how we go with the keratome, and we cut as we go in, and keep it a little centripetally, the keratome, so that we create a corneal valve even at 3 o'clock and 9 o'clock. We will demonstrate the corneal valve. So here is the one end of the corneal valve, and that's the other end of the corneal valve. So we have a 9 millimeter internal incision through which this big nucleus, as you will see, comes out. So this is a very hard nucleus, and we must also be liberal about the scleral pockets, because these nucleuses would be thick. So we need to accommodate the thickness of the nucleus in the scleral incision. So this is how, just by posterior lip depression. I think this is another thing that everybody should be careful, that never we should pull up if you are using the irrigating vectis, because then we can injure the incision. If the other thing that we can probably do is to break this nucleus or bisect the nucleus. This is a very supra-hard cataract where phacoemulsification was started, but you can as well see that the energy levels has gone up to 48, and still we haven't done much to the nucleus. So essentially it was converted, and this is the snare technique, which is, I think I've talked a lot about it. We find it very useful. It just goes like a knife in the butter, and you can cut and divide the nucleus into two. And then, of course, one thing is, people think that this will probably work through a very small incision. No, because the nucleus is thick, the snare has to open 5 millimeters to go around the equator. So essentially the incision has to be externally 5 millimeters. So essentially these are the basic points that I wanted to share about dealing with our nucleus. And I think we can take up a few points in the discussions as well. Thank you.
Thank you, Dr. Debashish sir. I would like to know the snare technique what you demonstrated. How do you prepare the snare? Do you prepare by yourself, or you have the snares ready-made available with the instrument companies?
No. It is available with some instrument companies, but it's a very simple instrument to prepare. You can actually take a 20 gauge needle, the IV needle, blunt the tip on those any sandpaper or something, and then rub the side, this side, this side, and then the other side. So you have made two openings on the tip of the needle. You have two eyelets. So through, you take the A1 string of the guitar and pass it through that. One, make a loop, pass it through the other eyelid, and both of them come out through the hub. Now this wire which comes out, now you can use it as a snare, or to be more on the safer side, you can take another needle and put that outgoing two wires into the second needle and press it. So then you can have the hold the needle in one hand, the snare, and then when you pull the second one, then the lasso tightens. So this is the simple way of doing it.
And there was initially when this bisector and trisector technique was started for hard cataracts, we used to have this bisector and trisectors. One was from Maharashtra, Dr. Bhide. He had invented Dr. Bhide's punch, by which this hard nucleus, by using this punch, one kidney-shaped part of the nucleus was dissected out, and then the whole hard cataract is to come out. So there are various techniques.
Yeah.
You nicely demonstrated the collapsing of nucleus to the bag into the anterior chamber. So, Dr. Sudhir Mashavde, what is your take on SICs in suprahard cataract? Dr. Sudhir, are you there? Dr. Satanshu?
I think Dr. Satanshu is not there.
Satanshu is not there. Okay, Dr. Parikshit, what would you suggest? What are your preferred technique for managing suprahard cataract?
My technique for managing suprahard cataract would be just doing it by visco expression. Of course, Devashish sir is a fantastic surgeon, one of the greatest surgeons. So it's okay, but to put in even a snare in a very, very, what shall we say, when the nucleus is very big. So putting in 2 or more instruments takes a lot of skill, and you really have to have a very big incision. So the best thing I think would be is to make the incision very large, as Bhattacharya sir said, and to see to it that there is an ample amount of viscoelastic both below the nucleus, over the nucleus, all around it, and use either a blue menthol technique or use a visco expression technique. Personally, I do a visco expression technique.
Okay. How large a tunnel would you recommend for a hard cataract? I mean, when would you like to suture this SICS tunnel? If it is more than 6.5 millimeter, 7.5 millimeter SICS tunnel, would you like to suture it, Dr. Basim?
Yes. Yeah.
For me, you are
asking. For a large tunnel,
we should suture it. We should put 1 or 2 sutures in all these cases, and because of the safety and security. Otherwise, many a times we have seen the leaking wound even after years of this surgery, because these are hard cataracts. Dr.
Parikshit, you want to add something?
No, what you said is perfect, Basim sir. It will prevent leak, but more importantly, it will also lessen the astigmatism.
Astigmatism. That is true. That is true. And one question has come from Dr. Manveer from our society for Dr. Devashish, that can we do can opener capsulotomy?
Yeah, definitely we can do. Definitely we can do. Can opener capsulotomy, because here, you know, the biggest thing with the rhexis in a SICS, essentially when we are putting a PMMA lens, the only function is that we can very safely and quickly clean the cortex without the fear of catching a tag and pulling. But in a suprahard nucleus, you have hardly any cortex to clean. So essentially, obviously, when we are doing a big rhexis, if it is within the skill and purview of a surgeon, fine. Otherwise, the envelope capsulotomy or even a can opener capsulotomy is perfectly fine. The second thing that I wanted to add to what Kurinder said is suturing. I think you would go back to the second video where I did the corneal valves up to 3 o'clock and 9 o'clock. See, when you, it's not the size of the tunnel or how big you have made the incision that decides the astigmatism. The astigmatism is decided by the tissue slip. I mean, if the incision slips or if the floor falls down, if it is watertight at the end of surgery, as we showed in that case, then sutures are not required, and neither would it give a huge astigmatism, because whatever flattening will occur on the left side will be compensated by the flattening on the other side. So the astigmatic component of the incision is only the central part. It is not on the sides as we assume, because this flattening will be compensated by this flattening. If you, Purinder will understand, because
Yes, sir.
Vector forces, yeah.
and same,
I think
Yeah, I can understand.
Dr. Tiwari will endorse me.
Yeah.
He is
Can
very
I
fond of
can I
astigmatism.
make a comment
yeah,
about
Yes, sir.
the
Yes, sir.
astigmatism stuff?
Yes, sir.
The astigmatism is essentially decided, and it depends on the vertical corneal instability. The larger the vertical corneal instability is going to cause more of a wound recession, as Dr. Devasis Bhattacharya said.
Perfect,
So there is perfect.
That's
But there is a point. If you are making a fairly large incision like 9 millimeters, the risk of the wound leak is pretty high. And I would personally suggest a horizontal suture. If you are not comfortable with a horizontal suture, which is quite astigmatism friendly, then maybe you can go in for a 1X suture in the center.
I think very nicely compared. But what I personally feel is for hard cataracts, even if you make a tunnel of 7.5 millimeter, any hardness of the cataract can be delivered by this tunnel or 7 millimeters or 7.5 millimeters. And if your tunnel
The
is properly
hardness which Dr.
constructed,
Devasis demonstrated is going to take
yeah,
9 millimeters.
if your tunnel is properly constructed, then suturing the tunnel is not required. If your tunnel is posteriorly placed behind the limbus, if your lateral horns are properly done, properly made, then you don't have to suture the tunnel for hard nucleus or for a tunnel which is more than 6.5 millimeter. That's the reason I asked this question, to highlight this point and the myth that we have to suture the tunnel if it is more than 6.5 millimeter. It is a myth. What we need is to understand is what is the integrity of your tunnel. If the integrity of the tunnel is maintained, and if the wall mechanism is functioning and there is no leak, if you find a nice hard globe at the end of the surgery when you do the hydrodissection of the side port, then you have to decide whether you want to do the tunneling or no. One more thing is what Dr. Devashish demonstrated, the bimanual technique of nucleus delivery. What is your take on that, Dr. Sahu? What would you recommend? A bimanual delivery technique. You have to unmute yourself. You have to unmute yourself. Dr. Sahu, you are muted.
See, any technique needs expertise. If somebody is doing it bimanual and mastered that technique, it is good for him. See, if I do a nudging and take out with a dialer, so that is okay. You cannot say that any technique is bad. It's a question of mastering a technique.
Okay, Dr. Devashish, what would you prefer? Which visco would you prefer in this suprahard cataracts? Will you do with your will you do away with your HPMC, or would you recommend viscoat or chondroitin sulfate when the dispersive viscoelastics?
No, see, I mean, we have to be good at the incision, and the incision must be compatible with the breadth and the thickness of the nucleus.
Size of the nucleus.
And in any way, I cannot afford the nucleus to touch on the endothelium. So the viscoelastic is not important. It is not, we are not doing phacoemulsification where we are, spreading energy or, aerosol energies inside the eyes. We are just manually helping the nucleus out. So we should make 100% sure that it doesn't touch the endothelium.
And this way, again, what you have stressed, we don't need a dispersive viscoelastic substance, proves that, in phaco, whenever you have a hard cataract, we always say we need a dispersive viscoelastic to protect the corneal endothelium.
Because
whereas in SICS,
because
whereas in SICS, we don't need this dispersive viscoelastic substance.
All of it cannot be focused on the nucleus. So
because a lot of energy and time taken in phaco in hard cataracts is more. That's the reason. I think we should go to the next presentation, Doctor.
The next presentation is by Dr. Rajesh Joshi, and he's basically going to talk on SICS in challenging cases. Dr. Rajesh Joshi is head of cataract and IOL clinic in Sadhguru Netra Chikitsalaya, Chitrakoot, and he's got special interest in tackling complicated cataract cases and in handling toric IOLs. So over to you, Dr. Rajesh.
Hello.
Wonderful surgeon.
Good evening, all.
Rajesh, you have to go for slideshow.
Yeah. So good evening, all, and thanks to both the societies for organizing and inviting. very quickly on to the some challenging cases. There may be many kind of challenging cases, but what I would be showing, you can see in the picture. So the above three cases you can see are the decentered IOs. They were operated long back with the ISMSICS and now with malpositioned IOL with or without vitreous into the chamber and with compromised capsular bag, of course. And below three, you can see are traumatic cataracts, and these cases are also old traumas with penetrating injuries with partly absorbed cataract and varying grades of posterior synechia. So if one by one see, this is the first case with decenter IOL, and you can see the IOL is lying in sulcus with decentration. PCO is there and the bag is fused. So there is no question of putting back the IOL into the bag. So the idea is to make a posterior capsulotomy with the vitrector and capture the optic into the that opening so that the IOL is fixed and it doesn't need further manipulation or further future surgery it may not require. So it is the case with a single piece PMMA IOL. So ideally, I would suggest a 3-piece IOL for capturing the IOL design. But if surgery can largely be done with the 2 side ports, though it is a little difficult with 3-piece, but it can be done at times, and surgery is largely completed with 2 small side ports. Similar, this case was present with a smaller pupil with vitreous in AC. So iris hooks were put in these cases, and we could see that there was little zonular gaps in the periphery after putting hooks that were lodging the haptics and causing large decentration. Again, in this case also, rexis means a posterior capsulotomy was made with vitrector, and the same PMMA IOL again with 2 small side ports was captured, and it got good stability in this case also. This is a traumatic old cataract with varying grades of fibrosis, fibrotic bands, and capsular plaques. So using scissors with multiple angles, the fibrotic bands were released. Plaques were peeled off the capsules, although at times it seems to be a little scary, but it works. And in traumatic cataracts, the plaque can be peeled and leaving the capsule intact. And at the left side, you would see there is Somering's ring with organized cortical matter that was also expressed. But at the end, I found that bag is not very perfect to put an IOL in the bag. So again, decided to make an opening with the vitrector. That opening should be very much central and should be adequate size. It is little 1 to 2 millimeter, little smaller than the optic size. Here, the 3-piece IOL is the choice. So again, to give the extra stability, the lens is the optic is captured. And this was, you can see the inferior subluxation with extensive fibrosis on the anterior capsule. So multiple side port incisions were made to get a good amount of capsulotomy. The nucleus was very soft and then was fluid only. Again, few more incisions were made to give it a perfect central openings where, so CTR in this case cannot be afforded because it is a compromised rexis and putting CTR may cause further damage. So I tried to do a sulcus implantation with capturing the optic into and got the good result with unstable IOL. This was a case with, again, you can see converting injury, and there were extensive synechia on the left side between the capsule and iris. So the fibrotic bands of capsule, whatever the remnant vagus was there, so it was enlarged again to give an opening, what I call is capturable opening. So the sulcus was almost absent onto the left side of this particular case, but there was iridocapsular complex under which the left side edge could nicely be captured and the IOL was stable. Otherwise, you have to leave this IOL. So, and there are too many cases. Like this is the extreme case of absorbed kind of senile cataract, and you can see a line, horizontal line in superiorly, which is line of fusion of anterior and posterior capsule. So again, in the back, IOL would be decentered if we try it. So again, is done with the same thing, a capsular opening. Here it is made in capsule and captured by putting IOL in sulcus. Again, with fibrotic membranous cataract, did with same thing, large decentration, and the answer is same, capturing the IOL in 3-piece IOL. And this was a case which was operated in the childhood, presented to me at 30 years of age, and before that, in the 30 years, he has undergone repositioning surgery for IOL almost twice, and again it got decentered. So the answer here was to capture into the remnant of opening, and we got good result in this case also. So I would say that if the bag is not very perfect and there are varying combinations of fibrotic capsules or smaller ZD or PCR, then still we can achieve a centered and stable IO by doing an optic capture. Thank you very much.
Thank you, Dr. Rajesh. Can you stop sharing your screen? The question is Dr. Sivamarthi. Dr. Sivamarthi, Dr. Rajesh demonstrated managing small pupil with ISMSICS. So what are the various tips and techniques you would consider in managing small pupil? Dr. Sivamarthi?
Yeah, thank you very much. Small pupil is will make a big problem, right? So the first time we have to make sure that the pupil can be dilated well. But if cannot, we have to use the adrenaline to intracamera with the certain dilution. And after that, if it's not possible, again, we for the expert with the experience, they can doing that, bring the nucleus into the anterior chamber, but we not allow to the beginner to do that, because by the technique with the ISMSICS, we can bring it into the delivery the nucleus into the anterior chamber. That is the most difficult actually for the small pupil. But for the many experience, that a lot of experience of the surgeon, then we can do that, but not for beginners.
Dr. Mahashabde, are you there? Dr. Mahashabde? Dr. Mahashabde? Dr. Vasil, what would be your preferred technique to manage small pupil in case of SICS? How would you?
ISMSICS are I think that can be done, that can be used, and they are fairly easy to use, and we should keep them handy when we use when we do the small incision cataract surgery, because that gives an idea where the rhexis is going and to what extent we can go to the rhexis. And it all depends on the type of cataract also. If the cataract is soft, if the nucleus is soft and the type of cataract is soft, then you can do away with a small pupil. And again, what is the size of pupil? If it is 4 millimeter or so, then we can complete the case without using any accessories or gadgets. But if the cataract is hard and the pupil size is 3 millimeter, 4 or less than 4 millimeter, then definitely we have to use the gadgets. And the most preferable, I feel, is in SICS is the ISMSICS.
Okay. So for the residents who are watching this, the point-wise approach to manage a small pupil would be that, as Dr. Sivamarthi told, first try to use intracameral adrenaline and see whether the pupil dilates. If it doesn't dilate, then you can do a stretch pupilloplasty and see if the pupil dilates. If stretch pupilloplasty with tube propylene soup doesn't work, then the options left is either you can do a multiple microsphincterectomy so that the pupil dilates, or you can use ISMSICS. So these are one of the techniques of managing small pupil when you're doing SICS. Another thing Dr. Rajesh showed was optic capture. Dr. Devashish, I would like to ask a question to you. If you are having can opener capsulotomy, or if you have used Vanna scissor to cut the capsule, if it is calcified, would you advise optic capture of a 3-piece IOL?
These were very good videos and very good management shown by Rajesh.
Yeah.
Actually, we don't get these PDF haptic lenses nowadays. I mean, these lenses.
Aurolab is manufacturing these 3-piece.
Because he has worked with the eyes which have no sulcus. The sulcus is gone, because sulcus is only it's a hypothetical space which exists only immediately after cataract surgery. But once the iris fuses with the anterior capsule, the way the cases he has done, everything is fused. There, actually, if you try a one-piece PMMA lens, it won't work, because you cannot dial the lens, it won't go. And probably these PDF haptics, they find their way somehow through these things. And Rajesh did a wonderful job. No, I think, with the skills that he has, and he does an anterior vitrectomy. So the chances of this, what you wanted to point out, that while you are doing the optic capture, would you extend the one of the cuts to
No,
the
no, no, no. My question was, my question was,
So,
Dr. Debashish, my question is, if you have done can opener capsulotomy
yeah.
and there is a rent, would you do an optic capture?
In a can opener capsulotomy, if you have a rent, then there is a problem.
Yeah.
Then there is a real problem, because you don't have a definite, and all these cases that Rajesh showed are cases of this, probably, if not a rent in the center, maybe somewhere the zonule had become weak, or the can opener had extended beyond the equator, where actually the haptic migrated. So these were the cases which Rajesh took up.
Rajesh demonstrated wonderfully all the complicated cases. No doubt, he's got great skills. But a take-home message to the residents would be: don't try to do an optic capture in case of a can opener capsulotomy, because you don't want your anterior capsule to run away and worsen the situation. So if at all, initial stage when you are learning, you have a rent, you take a three-piece lens and try to put in the circus. Three-piece lenses are available by Aurolab. They manufacture this. So thank you, Rajesh, for the wonderful presentation. Great skills demonstrated. So now we go to the next presentation by Dr. Amulya Sahu. Dr. Amulya Sahu needs no introduction. He is the founder chairman of this ISMSICS society. He's got good number of publications. He's talked at various national and international forums, and his favorite topic is mini SICS or sub 2 millimeter SICS. I've seen his talk in various conferences. That way he demonstrates this mini SICS is remarkable. We all should learn SICS is not 6 or 7 millimeter. It can be a 2 millimeter SICS also. So this is a great technique. There are a lot of modifications done by various surgeons. So now I invite Dr. Amulya Sahu, our founder chairman of ISM SICS Society, to come and present his video. Thank you, Dr. Sahu. All yours.
Yes. Well, thank you very much, Amit. 2 millimeter journey has taken a long time, and I demonstrated a live demonstration in Bombay in 2005 in 3 millimeter, and after that it took a long time. I had a live demonstration in Jodhpur in All India Institute, 2 millimeter, and the results, they said, I had not followed up next time. They said it is 6/9 vision and it was excellent. So that was then. After that, I have done not quite a number of studies on that. I don't want to go into details. So I will straight go for my, see, before you go for 2 millimeter, why 2 millimeter? Many people say I'm happy with 6 millimeter, like MS Ravindra also, and many of our outstanding surgeons, they say, why go less? But I was facing this when I started this chapter. The ISMS says the most, the only thing the phaco surgeon has the pride is that I have a small, very small incision, you have a big incision. So I was just thinking, can we go smaller? So when I demonstrated 3 millimeter, Haldipurkar said that if you go anything lesser, the phaco surgeon has to find another place. So that was a challenge, whether we can go, and to reach there, a lot of instrument modification I have done, and that has given me very easy to do this surgery, and with excellent results, which we are recording. And I have done this presentation as 65 patient study, and I have done the endothelial count with Conan, and these are the instruments. I'll say very smooth. I have a jet, single jet cannula. What is the difference between the jet cannula we are using now and what is the difference? It has an opening on the top. So when we are doing a jet cannula, we are injecting in a particular spot and it is going and hitting the zonules. But in this jet cannula, there is a flush of liquid goes and it delineation becomes better. Then I have a multiple jet cannula where you see many time patient complain of some sort of irritation and unhappiness. The irritation you cannot explain what is happening. So that this cannula flushes out all the debris, and the debris which remains inside creates irritation, and this multiple jet cannula does that. Another thing is that this is a viscoelastic cannula, as you see, that it comes in a rounded face. So when it is a rounded, you are pushing through a side port which is square, it has a chance of descent separation. So what I did with artery forceps, I compress it and make it rectangular. So I have manufactured that also, that so that it is available. Now this marker, because I am now doing with any steep axis, I want to give the incision on the steep axis. So this marker I have developed where you can exactly mark 2 millimeter. And what I do with that, how I will show you in my video. So this is a marker, and this Simcoe cannula is also gauge is reduced. So it is what cannulas are now available is a big cannula. So for that you have to increase the side port size. So I have reduced that gauge, and I have made it there is a oval. Now the rounded opening is there, but I have made it oval with a hanging edge in the top, so that the negative pressure is built up and sucking of the cortex become easier. Now that this is Vectis is a very important part of these things. The size has been reduced and the gauge has been changed, and in the front also there is a hanging edge which engages the nucleus which after the breaking, so it can be glided out. So now this
Sahu,
whatever.
can you
Sorry
go
to
for a
interrupt you.
slideshow? Can you go
Hello?
for the slideshow?
Okay.
Yeah.
So
Because the instruments are not visible.
Sir, make it a slideshow so
Yeah.
it will be seen better.
Slideshow.
okay.
Full screen, sir. Slideshow full screen.
Lower right side clock R.
Screen.
Lower right side. Sir.
Right.
Lower right.
Screen
Lower
का
right.
screen कब
Below,
click
below.
होगा?
Here, what is
Down,
that?
down,
Sir,
sir.
नीचे नीचे एकदम नीचे.
Yeah, just left to
थोड़ा
this,
left, थोड़ा left,
थोड़ा
left,
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 left.
left.
That
Or left.
cup like thing.
Yeah,
हाँ,
this
that.
one.
Yes, click on this. Yeah. So now the instruments are visible.
Now this Vectis is I have modified and size has been reduced, and there is a strength there which engages the nucleus and brings it out. Now the dialer is, you see that it is not the dialer which is available. They are straight and very fine, but the gauge has been changed, and the tip has been not made vertical. It is little bent there. So with that I pull the this rexis margin towards myself and go behind the lens and nudge it out with one go. So these are the modification, and some other modification I have not shared here. So that will help you to go reduce the size of the incision without damaging the endothelium and other things. So now I will not go into detail. I will straight go for these are endothelial counts of the Conan which I had to invest on that just to prove that the endothelium I am not buggering up. So now this is a topo-guided incisions, and I have kept this thing in the first day. You can see the vision improvement because the air bubble is seen, so that it is not it is immediately first post-operative day. And cylinder number reduction and everything is there, but I will straight go for the video. And this is the significant, astigmatism reduction is there. Sorry, I have to.
Video, sir.
I forgot the video part. So bear with me.
Yeah.
screen sharing. I don't know.
So
where
video
I-
was not there in this presentation. The
The
PPT.
video is there.
Video. See that thing.
Maybe try going back.
Huh?
Yeah. Try
Try
going back.
Try going back. Even before the instruments, some
Hmm.
previous slides are there, I think.
Yeah.
Yeah, go back. Keep going.
हाँ.
Yes.
हाँ sir. अभी आया.
हाँ.
Now the video has come.
So now you see that I separate the conjunctiva and canons separately, and then and as you see that I am not holding the sclera or the lip of the incision, I am holding the conjunctiva. I give a 1.5 millimeter back cut if I am putting the lens directly, and 1 millimeter back cut if I am injecting it. I do the axis through the side port. I give 2 side ports. Regularly do the staining. Sometimes I use the left hand, as you saw that with the dialer I am holding the lamp eye straight, because I don't give any superior rectus stitch. So just to keep it focused properly, I use my left side port to stabilize the eye, not always, but sometimes. Just to assure that I remain within 2 millimeter, I give this back cut so the incision size remains 2 millimeter. And I take advantage of the pocket I create to dial the lens directly inside. Now this lens has been broken in the tunnel. Sometimes I break it with my visco elastic cannula and backtist behind. I break it. I think I may use the snare, because Anil Shah, who has mastered this, promoted this snare thing. See, he has said that he has developed a technique where we can put the snare inside 2 millimeter and break the lens. So I will learn from him, and then I will use it. This is a polishing of the posterior capsule. Now you see that directly I am using the pocket to mobilize the lens directly inside with the 2 millimeters. The dialer is made in a way that it takes the corneal contour into mind, and is done in similar way. It is not a straight dialer; it is curved dialer. So if you can give astigmatic free, there are other ways in a bigger incision. Dr. Boramani will tell how you can do the wound modulation and do a astigmatic free things. But in these cases, I am finding exactly, next day you get hardly any number is there, for distance. I will go for the next video where I have.
So go back.
I'm going back.
So click on the video, yeah. You have to click on the video.
Huh?
Second video. Click on the second video.
That's what I'm doing, but it is running away.
हाँ आया सर, नीचे नीचे.
I think this is a voice over and he's hearing that. You keep talking, please.
Hello.
It's not coming to us. Yeah.
I don't know. So anyway, it is nothing much different from the first video. Only the voice recording was there. After this step, I think you can fill some questions. That will be much better. So that was, I was showing that at the 2 millimeter, I remain with 2 millimeter. So we can go for the questions.
Yeah, excellent, Sahu sir. 2 millimeter SICS is something really amazing. It's a challenge to do this SICS surgery with such a small incision. I would like to ask who among the panelists, 7 of our panelists, who does this mini SICS? Does anybody do mini SICS from the panelists? Dr. Basim, Dr. Premchandani, Dr. Mahashabde, Dr. Sivamarthi, Dr. Gopte. Anybody does a mini SICS less than 6 millimeter? Dr.
I
Parikshit
don't
is
know.
smiling. That means I think it's only Dr. Sahu among the Dr. Boramani asked among the panelists. So
Yeah.
among the panelists, nobody is doing a mini SICS.
You
but it's
need a very strong heart to do
yeah,
that.
yeah, that's what. One thing, Sahu sir, all your instruments, most of the instruments which you need for mini SICS are invented by you. So if somebody wants to start mini SICS, from where they can procure this instrument?
Okay, I have a plan. After the COVID, I will go to each state and teach some masters 2 millimeter so that they can create a legacy there. So
No, I'm
now,
asking from where do you get these instruments? If
my
somebody wants
instrument
these
are made
instruments,
in Bombay only, but I am thinking I spoke to some Israel people whether they can design it and package it, but didn't. They said that they at this moment they cannot do it. And as in India, we don't have that developed that kind of expertise where you can brand it and keep it in a packet and give it to people. So I'm looking, if you know anybody, you can refer to me.
the Epsilon is an excellent person. Epsilon will manufacture anything what you want, and
He's
you
at
can talk
Epsilon
to
Bombay
fellow
him.
only.
had come to
Yeah.
Epsilon fellow had come to me and see my surgery, but after that few steps and he just lost. So that these
Okay.
kind of things we have got inertia of action.
Okay.
Initial
Sir,
inertia.
no words to tell about your surgery. It is excellent surgery. I think we'll go for the next talk by Dr. Boramani because it is going to be some overlap because he does this small mini SICS to control
So
the astigmatism.
Nikhil came to my OT to see the surgery. After that only he got interested in MSICS.
And he started sponsoring all our sessions.
They are baking after seeing my surgery. Okay.
Okay, so we go with our next talk with Dr. Jagannath Boramani. He's going to talk on managing astigmatism with SICS. So to introduce Dr. Jagannath Boramani, he's executive chairman of ISMSICS. He has won 6 awards in Moscow, namely the first prize for paper in PG section, Dr. YKC Pandit Award, Innovation Ophthalmic Practice Award, Best Academic Private Practitioner Award, VK Chitnis Oration Award, and the Best Video Award. He also won the Scientific Vision Award of AIOC in 2014. He has done live surgeries at various national and international platforms. So over to you, Dr. Jagannath Boramani, for your talk on managing astigmatism with SICS.
Yeah, thank you, Dr. Abid, for the introduction. And I thank the entire team of MP chapter of ISMSICS. Can you hear me?
Yeah, we can hear you.
The entire team of MP chapter of ISMSICS for giving me the opportunity. This is my very favorite topic, the managing astigmatism in SICS, because in most of the SICS surgeons are not going for premium IOL because the risk and tension of inducing a very high astigmatism is there. But if you can utilize this bad property of SICS, induction of a high astigmatism, to our benefit, then on the contrary, you can put the premium IOLs also with more confidence, and I'll show you how. Scleral tunnels are generally very secure incisions. They heal also very well. They are covered very well, and I call it them as a forgiving type of incisions. A little raggedness here and there, little more cauterization here and there, it will not have a much effect on the astigmatism. Astigmatism mainly depends on the location of the incision, the length of the incision, and the distance away from the limbus. So you don't case all the cases with perfect steep axis, that to only perfect 0.25 or 0.5 in the horizontal meridian, so that you'll have a 2.8 mm corneal incision and neutralize that. You get various types of incisions. This principle of incisional funnel is very well known, but we try to make more curved incision because this is a concept of the prawn incision. Why this incision has been made more curved? The ends of the incision should go away from the limbus so that the induced astigmatism is less. So a straight incision induces more astigmatism compared to a curved incision. So I thought of making the incision more and more curved depending upon the pre-existing astigmatism and try to find out my own results. And then I formulated my own algorithms. Now these are my algorithms. If you want to neutralize about 1.69 diopters astigmatism with a steep axis which is vertical between 60 and 120, then you have to take a straight incision of 7 millimeters, progressively reduce the size of the incision to induce less and less astigmatism. Now make the incision little curved, the induce or the neutralization of the astigmatism is comparatively less. And if you come down to a perfect U-shaped incision, astigmatism induction is almost nil. But the temporal incisions, they are comparatively weak in inducing or neutralizing the astigmatism because they are away from the optical axis. Even a large straight 7 millimeter incision will neutralize only one diopter of astigmatism. So to make an astigmatically neutral incision, you can have a temporal incision and a curved incision that will almost don't induce any astigmatism. The superior temporal and superior nasal incisions, they act in between. Now to have a perfect result, as Dr. Devashish also said, that the incision should be equally divided along the steep axis. Say for example, your steep axis is 140 meridian. Whatever may be the shape of the incision, half of the incision should be on one side, another half of the incision should be on the other side. So all the vector forces from the astigmatism, they are perfectly acting on the steepest meridian and you get a good result. Now question is, where will you sit for doing the surgery? Now you have to sit according to the steep meridian. The nose is coming in between, so the nasal incisions are a little difficult, but if you go 20 degrees away, then you can get a perfect hemicircle and you can keep the incision on any of the axis depending upon your steep axis. So there are the softwares available for calculating the induced astigmatism, because this is not a mathematics. If one diopter is brought down to 0.5 diopter, it may not be only 0.5 diopter of induced astigmatism, because the axis might have changed and the vector forces come into the play. So to put your results into the software, put one type of incision in one table. Say for example 7 mm and superior, put all in one table, and after doing say about 15 or 20 cases, you can find out what is your average induced astigmatism, this type of incision. Similarly, put all your temporal say 5 mm in one table and try to find out how much you are inducing. So this way you can calculate your own algorithm. My algorithm might be a little different from your algorithm. Now before going to few videos, I'll show you few results. Now all the post-operative topographies are done approximately 20 days after the surgery. Now this is the first case where astigmatism is very less, 0.28, and it is a superior one, like a vertical meridian 100 degrees. So I have taken a U-shaped curved incision. It is not a perfect U because I want to neutralize a slight one, and this has come down to 0.18. Next case, 0.39 superior temporal, a little less curved, has come down to 0.22. This is a case the astigmatism is a little high, 1.12, and the steep axis is 97. So exactly on 97, I have placed the incision, which is about 6.5 millimeter, and you get the end result as 0.15 diopters. This is another case, 0.4 temporal, which has been brought down to 0.09. This is again temporal 1.24. So have a large straight incision temporally, and you can neutralize almost one diopter. This has come down to 0.34. This is another case where the astigmatism is almost nil, 0.13 only. And here I have not induced any astigmatism, it is 0.17 only, and have had a curved superior temporal incision. Now this is an interesting case. This came to me 3.49 diopters, a very high astigmatism, and the patient was not affording a toric IOL. So here what I have done, here this also I have brought down with an SICS incision. It has been brought down to 0.64 with a 7.5 millimeter straight incision. I would have come slightly closer to the limbus, and perhaps I would have been able to neutralize that 0.6 diopters also. But this was a tremendous benefit to the patient who couldn't afford a toric IOL. This is another case. This is an affording patient who came with a high astigmatism, 3.3 diopter. If you see 3.3 diopter, you will always advise a toric IOL. So for this patient, I gave him two options. One thing is that go for a toric IOL, you have to pay high for the lens, or you pay more surgical charges to me, I will neutralize this with my own method. And this was brought down to 0.56 with a straight incision. Here the surgical charges are more, so you can sell this or market this as a premium surgery without using a premium IOL. Now these are the cases of multifocal IOLs, because once you get confidence and know how much astigmatism you are going to induce, you can put the multifocal lenses without any tension with a full confidence. This is the case 0.33 diopters of astigmatism with steep at 129, again with a curved U-shaped. It was further reduced, or very slight reduction, 0.3 diopter was the end result. This is a case of high astigmatism. This was a doctor patient who was operated before the COVID era. He wanted multifocal lens. Patient himself was a doctor, and astigmatism was 1.97. And this steep axis you can notice is 170. So on auto it was showing as 165. So what I did, I placed the incision on the steep axis 165. This is the left eye, and this is the nasal side. So the incision on the superior nasal side based on 165, and that was totally neutralized. The residual astigmatism was only 0.15 diopter. This is a case of multifocal IOL doctor patient, and he is enjoying a perfect vision 6.6 and N5 without any refractive error. So now I don't call this as a surgically induced astigmatism, but I keep calling it as a surgically corrected astigmatism. This terminology was suggested to me by Dr. Ravi Trehan. And even SICS in my methodology, I don't call it as an SICS, it should be CICS, the customized incision cataract surgery. Because this first is something like unwanted pregnancy, and the second one is a planned child. Now to have a perfect results, you should mark the steep meridian using all the instruments which are used for a toric IOL. So you mark the references 0 and 190, 0 and 190 degrees with a reference marker. Either use a bubble marker or street lamp marker. And then once the marking is done, you place your incision exactly. The center of the incision should be coming on the mark. Now here the marking need not be on both the sides. It can be only on the side of the incision. For example, here 39 degree is the steep. So I have marked the 39 degree. In the left cut is 70 meridian. The incision on the left side is a curved one, and the 39 meridian right side is a straight one, because it depends upon the pre-existing astigmatism. So by marking even whatever the 10 degree cyclorotation may take place in patients lying down position, that error also is avoided. Only question is that if you have got a hard nucleus and you have to manage through a very small incision, like say now this is a less than 4 mm sub 4 mm incision, but I'll skip those videos because we don't have much time, and this is a totally different talk. This is a totally different talk altogether. This is my method of phaco-fragmentation and spiral tunnel, but I'll not show you these videos because it will take unnecessary time. Now, the advantage of this technique, now there are two cases with me. The first case is having 2 diopters of astigmatism pre-existing. Second case is also 2 diopter of astigmatism. The steep axis is also exactly same. I am planning a reduction of 2 diopter or neutralizing 2 diopter. But this is a human eye, so you cannot have a perfection every time. So there is an undercorrection now. So with the undercorrection, only 1.5 diopters got neutralized, and the patient's end result is plus 0.5 diopter astigmatism, cylindrical power. In the second case, same incision, same methodology, but maybe you got an overcorrection. Now with the overcorrection, he has crossed the 0 line, he has gone on the other side. The total reduction is 2.5 diopters, but again the patient has ended up only with minus 0.5 diopter cylinder. So even with a range of error, even if there is 1 diopter, slight undercorrection or overcorrection with your methodology, still the end result with range of 1 diopter of error, still the end result is less than 0.5, either on the plus side or on the minus side. The axis keep changing, but this is the advantage of this methodology. So most of the times you are on the target. Even if there is some error, you are not landing up with a very high and surprising astigmatism, and you can put the multifocals with more and more confidence. So with the customized tunnel engineering, it is possible to wipe out or at least minimize the stigma of astigmatism. Thank you very much.
Thank you, Dr. Boramani, for nicely enlightening how to manage or tackle astigmatism with customized incisional cataract surgery. These 2 new terminologies, what we heard today, they are excellent, and I think this is the way to go for all our SICS surgeons. So one question I would like to ask you, Dr. Boramani, what is the role of OCCI? Do you practice OCCI and CICS?
Yeah, I have practiced in few cases in a very high astigmatism. Patient is not affording toric. Now, you have heard my talk. It doesn't mean that I don't put toric IOLs. I put toric IOLs. If it is more than 1.5 diopters or more than 3 diopters, with superior steep axis, then I take the help of toric coil. But these are very rare cases. But especially if the steep axis is temporal and say patient has got pre-existing 2.5, sometimes I put toric coils. And in very high astigmatism, say more than 3 diopters, I've taken the temporoscleral tunnel and again the OCCI on the nasal side. So this way also I have tried to neutralize. So sometimes I do OCCI.
Okay. Dr. Parikshit, do you modify your incisions based on the steep axis?
Yes, I do. Definitely.
So it is superior and temporal.
I always do the incision on the steeper axis whether I do phaco or I do SICS as a rule.
Okay. Dr. Rahman, what about you? Dr. Rahman, please unmute yourself. Please unmute yourself.
Yes. Again, tell me.
How do you manage astigmatism in SICS? Do you place the incision on steep axis or you have any other techniques of handling astigmatism?
No, always I am giving in the incision in the 12 o'clock and a little bit front incision, and there is not too much astigmatism in my case.
Okay. What about Dr. Devashish? Do you modify according to the steep axis or it's a standard superior or a temporal tunnel?
No, generally, I would practice steep axis incisions for phaco as well as SICS. Yes, I always prefer to neutralize as much astigmatism as possible.
So, Dr. Amit, can I ask one question from?
Yeah.
Dr. Brodomani,
yes.
What is the maximum astigmatism which you have corrected?
Maximum corrected is about
by
3.5
by the incision alone.
3.5 diopters.
3.5 diopters.
Yeah.
So, but usually, how do you say that? How much astigmatism you would like to correct by? You are sure of that? Maybe I can correct 2 diopters, 1.5 diopters.
Yes. So I have formulated my own nomograms because I now know how my incisions behave, different shapes and different lengths in different locations, how they behave. So depending upon the pre-existing astigmatism, I decide where to take the incision. So maximum corrected is 3.5. So my range of correction can be between 0 to 3.5.
Dr. Bodramani, one thing I want to ask you is, can we shift on the steep axis, can we reduce the astigmatism by shifting our incision anteriorly or posteriorly?
Yes, that also I am trying.
Taking limbus as a landmark, to reduce the maximum astigmatism, we can go more anteriorly.
Correct.
Okay.
This is particularly in the case of temporal one. You can come nearer the limbus if you want to correct more, and the corneal dissection can be slightly more. So go slightly closer to the optical axis.
Yeah. So after viewing Dr. Sahu's video and your videos, I think we should in the ISMSICS Society, we can come up with a marker or a blade kind of thing, a U shape or a semicircular shape. How we have the Rexis marker, we can have something, a blade of that shape. We just imprint it on the sclera, so the groove is made, and then we make the tunnel. So that creates more standardization, and everybody will be able to follow a set pattern. Right now, what is happening is somebody does a frown, somebody does a straight, somebody goes anterior, somebody goes posterior. But if we come with a blade, like a groove marker, which has a sharp edge, a semicircular one, just mark it 1.5 millimeter behind the limbus and press it. So your groove is imprinted. Then you just have to make the tunnel. Something like Ranjan had come up with the Ranjan's marker.
Can I add?
I think Dr. Haripriya Arvind had this kind of thing. It was shown in one of the AIOs.
Okay.
Generally, my comment. Amit, can I make a comment?
Yeah.
What Dr. Boramani demonstrated is awesome. I mean, I'm really impressed. But I would like to make one comment that these are certain factors that are under surgeon's control, and there are factors that are beyond surgeon's control, like the tensile strength, the elasticity of the tissue, the dissection, the type of the dissection, how smooth was your tunnel, how the tissue heals, and so on. So these are the factors that need to be considered. Although we do derive a nomogram and go by that, the amount of the astigmatism that is induced is largely depend on the size of the incision and the distance of the incision from the limbus. But all in all, it was wonderful.
Amit, one point. Can I come?
Yeah.
One point.
Yeah, Dr. Sahu.
See, this is not a science. This is art. So let us enjoy the variations. Let us not come into a particular straitjacket. See, as you suggested, yes, a marker. When I'm doing a 2 millimeter, I must have a marker which gives exact specification. But variation is the real thing with us. Everybody is an artist, so they should perfect their art. That is what I wanted to tell.
Can I add one?
Yeah, Dr. Boramani.
There are two things. One, Dr. Tiwari's comments. It's all right because this is not a straight paper where cutting 2 + 2 it becomes 4, nothing like that. Because this is a human body, the healing pattern of every tissue is different. But as I told in the beginning, comparatively, sclera is little more forgiving tissue because it is elastic, it heals very well as compared to cornea. So the unpredictability is slightly more. Like instead of 2.8, if you take 2.9 or 3, your results are totally different. If you do little more stretching on the cornea, again results can be more different. So always I say sclera behaves like Mahatma Gandhi while cornea behaves like Osama bin Laden.
Okay. And so we take a last comment from Dr. Premchandani and then we move on to our next talk.
Yeah.
Dr. Premchandani, yeah.
Yeah, that U-shaped instrument you were talking about, we can take a marker pen and draw it first before going for an incision. That will serve the purpose also.
Can I add here?
Yeah.
Basically, even for my straight incisions, the ends are marked with the vernier, the ends of the caliper. But I even don't do the initial grooving with the straight because always mentally imagine what is your incision and straight away I start cutting with the crescent. The only advantage is that if you take a slightly curved incision, there is slight sagging of the wound. But at the periphery, the wound becomes very cosmetic, looks very good. So you always feel that after say 20 days of surgery, this is a surgery done through a 1 or 2 millimeters. You feel like that, even if your incision is 7 millimeter. This is only the cosmetic advantage. And as far as the marking is concerned, this marking is required mainly for the learner. But generally, learner should not worry about the astigmatism when he want to learn the SICS because he should concentrate on the endothelium. So my technology is for only experts who can manage nucleus in different types of astigmatism, not for a beginner. Because any beginner, if he sees my talk, he'll say, from tomorrow he'll come to know how much to neutralize, how much to take incision. And then he starts damaging the endothelium. That should not be done.
Okay. So thank you, Dr. Boramani. Now we go with the next speaker. The next speaker is Dr. M.S. Ravindra. He is basically the chairman of Karthik Netralaya in Bangalore. He's a managing trustee of Netra Jyoti Foundation. He's done his MBBS from Bangalore Medical College, the prestigious Bangalore Medical College, and MD from AIMS. He's done a fellowship in vitro retina from Shankar Netralaya and fellowship in cornea from Rochester University, USA. Even though he's a retina trained person, but he is the torch bearer of SICS with premium IOL in our country. Before I invite Dr. Ravindra for his talk, I take the liberty as a moderator for him to present this talk of premium iOS, a video based for 5 minutes, and also would like to advise him, not to advise him, would like to request him that, sir, after your talk, please share 2-3 minutes of your valuable time to give some valuable tips to our residents on how do we go ahead with SICS without superior rectus, with SICS premium IOLs, toric IOLs, multifocal IOLs. So in nutshell, I give you 7 minutes to teach our residents how to go ahead with SICS and premium IOLs. Thank you, sir.
Thanks to the Madhya Pradesh chapter, and congratulations and best wishes in the future. Much before anybody implanted a lens, I had the opportunity of taking one of the diffractive multifocal lens way back sometime in 1997 or 98, and I had implanted in SICS at that time. There are so many kinds of IOLs you're all aware of. Accommodative IOLs were tried, but they're not there. But basically, we'll have to be happy with the diffractive bifocals, jobs, and trifocals. Telescopic lenses have got a lot of value for the macular degeneration patients. I've implanted many of them of Israel origin, but they need a large incision like what we have for SICS. We have an Indian and imported lenses. I would like to stress the point that there's no difference in the quality between Indian and imported lenses, and try to implant Indian lenses because they are affordable, and the expectations in the beginning will not be very high on the patient side. Avoid on type A personalities who ask a lot of questions. Who is a type A? Avoid in pediatrics. Avoid in all conditions where there is a monofocal in the other eye, where there is irregular or asymmetric astigmatism. Anybody who had an RK or basic, any macular disease, you have to do an OCT before the surgery of any premium lenses. And whenever you have a doubt about IOL or stability in either of the eye, you're operating on the right eye, left eye has got zonular dehiscence or an injury or whatever it is, don't implant it, because all multifocals need a bilateral.
Can you speak loudly, please, sir? Doctor.
Okay. Fine. Thank you. Thanks for pointing out. Halos remain, but glare and star bursts have been eliminated. Am I all right now, Dr. Basak?
Yeah, you're audible now.
Fine. This has to be told to the patient much before. Always have an alternative. Tell the patient also an IOL, because surgical complication may hinder you from putting a lens inside the eye. You have to understand the visual needs, because you let identify where the patient keeps. If he has got a habit of keeping it closer, select a +4. 3.25 is the most often used. This is at the IOL plane, not at the spectacle plane. The spectacle plane power, this will be around 3, this will be around 2.25, this will be around 1.5. It will be less than that. These powers adds are at that level. These are essential. Meibomian examination is essential, lid margin is essential, and you need to do Shermer's test, and I would routinely do a fluorescence staining so that there is no corneal pathology missed. Endothelial specular microscopy, I do it as a routine. And then these are the things which you'll have to look at before. I don't want to go into details of that. The basic importance is that you'll have to target. You'll have to have a zero target emmetropia. How do you do it? Do a keratoscopy. All these are, you're aware of it. I trust on Barrett Universal 2 in most of the cases, and compare with Hoffer Q if the axial length is 22. I use only this, and Hoffer if it's less than 20. And if it's more than that, I use SRKT and Barrett Universal. That way you'll have less confusion. About 22, use SRKT and Barrett's. They should be identical. And below that, I use Hoffer Q and Barrett. This is the most important slide. I can even complete my lecture by this. Achieve reproducible results. This is one of the most important things. You have to take 25 surgeries right from tomorrow and do an identical surgery. Don't deviate anything, do an identical surgery, and then put the results and find out if you have achieved emmetropia. If you have planned to achieve 0, you should be achieving 0 or plus minus 0.25 or 0.3, something like that, and see whether your SIA should be vector analysis. Not that, to give an example, post-op is minus 0.25, 180. So if you don't consider the pre-op was 0.75, is at 90, your surgical astigmatism is not 0.25, it's -1. You have to add them because they're at 90 degrees. So this Warren Hill's nomogram will certainly help you to find out your axis, and you'll have to first understand your results over 25 surgeries. Then you can plan whatever you want. There are various kinds of lenses. It's good to have asphericity analyzed before that, then so that you can actually choose the lens that you're going to implant. These are the, I would skip this for the want of time. So how do you improve surgical skills? Before I go to the video, I'll tell you. You use all your 10 fingers for typing. This is one of the most important things. Don't use 2 fingers, and be very fast typing whenever you do it. That's one which will actually give a lot of freedom to your fingers to move in any direction. Do all kinds of surgeries, especially ISMSICS. I've seen if you leave this ISMSICS, your surgical skills drastically come down very fast. Use best microscopes, stereocoax eliminations for all surgeries, and use best surgical instruments. And the one point, if you have 1 point to take home, always video record every surgery. And on the same day, when the things are fresh in your mind, critically analyze it, watch it at home. You find out which steps were difficult, what are the steps, and how do you improve them. If you keep on giving feedback to it, the learning curve will be shortened. And which steps cause post-op. Examine the patient on slit lamp and see how much is striate. On slit lamp, if you've done a good surgery, the striate, whatever technique you use is all right. Your cornea should be crystal clear, and there should not be any striate even at the site of surgery. So if you have to achieve this, and only continuous feedback, you cannot say the nucleus was hard, had taken much time. All that is excuses. Okay. All the excuses, you'll have to give it away, and this is the only way you can improve it. Which steps caused a complication? If you see a video, then you'll know what complication you had and how to avoid it. Always keep in mind, whichever stage you are, there is always a better technique than what you're doing right now. There are a lot of lenses that are coming up, and this is one of the telescopic lens which has got huge future for such conditions where we have macular degeneration. I have a few videos. If time permits, I can show you.
Yeah, Dr. MSR, please show your video. And Rahul, please mute everybody. There's a lot of disturbance going on. Rahul?
Okay, sir. Okay, sure, sir.
Please mute everybody. Dr. MSR, please go ahead with your video. And I would also ask you, request you to please give some surgical tips to our audience.
Fine.
Some surgical tips on how we should start with a premium IOL. We all do routine SICS surgery, but there has to be some refinement when we want to implant a premium IOL, whether it's a multifocal, toric, or an anesthetic lens, a foldable lens. So, request you to give some surgical tips.
Fine. I'll give the topical anesthesia. The pledget is kept there. I do a combined.
Can you show your video? Can you show your video, please?
Okay. Is that visible now?
Yeah, it's visible.
Fine. So I always do. This is what standardization of the tunnel is very important. It's always for me a 6 millimeter tunnel. It's about a millimeter away from the limbus, and the conjunctiva tendons is small, and I don't have a side flare to control the astigmatism. It's a rectangular as the one I've done. I've injected visco into the eye, and the wound is not stretched at any point of time. Do a rexis, I'll skip it, do a very good hydrodissection, and bisect the nucleus and take it out so that the nucleus does not stretch the tunnel. So this way the fibers in the tunnel are saved from stretching and distortion, and that's, you put a lens inside the back. I'll go to the next. Yeah, you seal it up, so there is no external wound.
So you cauterize all your conjunctiva at the end of the surgery?
No, I do at the end. No, I put a glue there. I put a.
Okay, you don't cauterize the conjunctiva. You put a glue to adhere the conjunctiva.
Glue, yeah.
And
so
what is your take on superior rectus and how to go topical?
Fine. So you watch the surgery. There's no superior rectus suture. That's a steep axis. That's a lateral canthus. You always measure, as Dr. Boramani said, in every routine case, mark the steep axis and take the incision on the steep axis. Consider that every case you're putting a toric lens, and this is a direct limbal, and I'll run the video. And I've entered it on the scleral side of the limbus, and there is a small congenital flap there, and that's a 2.8, and I know exactly how much of astigmatism this tunnel produces. And do not try to do it right from tomorrow, because it needs practice. It's a little longer incision when compared to the phaco surgery. Do the rexis. One thing, yeah. So do the rexis. This is the enlarger. This width is 5.2 millimeters. So my tunnel, I know exactly is 2.5 or 5.8. I know how much of astigmatism it produces. Based upon, you asked a question where you're going to initialize the tunnel, depending upon, are you going to do it on the scleral side, posterior limbus, anterior limbus. I will not go into the clear cornea here at all. It has to be there. And see that the tunnel is absolutely rectangular. It needs practice to do that. And the other question you asked is how do you avoid putting a superior rectus suture. Superior rectus suture is only used to roll the lens eye downwards. It has got no value in cataract surgery at all. If you want to pull the superior rectus and push the eye downwards, you'll have to do it. But practice, you check the video, practice, your eye has to be looking at the microscope throughout. At no point of time, you should roll the eye in any direction. That way, the stretch on the rectus muscles is avoided and the pain is absolutely avoided. So here, because it's a 5 millimeter incision, you'll have to use an injector. You cannot push it directly. So the one of the most important thing is centering the lens. Here I'm taking a 6 millimeter stereocorneal incision. This is because of the astigmatic considerations. I know exactly how much of astigmatism this produces. This is again not exactly at 180. This may be maybe at 15 degrees or something like that. And roll it, and lens has to be, patient has to look at the light. You explain there are two lights and ask him to look at this light so that the visual axis, you know exactly where is it, and remove entire viscoelastic from the eye, from the back of the anterior chamber, from the angle region, remove all the viscoelastics completely, then form the chamber. The depth of the AC should be normal. Don't balloon it backwards so that there is no pressure on the haptics. And now you see it's not sitting in the center. It's outside. Now I'll rotate the one haptic of it till the light reflex coincides with the center of. This way you'll have best possible vision. You have avoided angle kappa by aligning it in a exactly opposite, not the opposite points, by aligning it so that one of the haptic is little on that side. So here, imagine the patient has got a 0.5 diopter steep axis in that axis. Then with this, I correct about 0.4 diopters of astigmatism by 6 millimeter by 2 or 2.5 millimeter, and the patient will be emetropic. Patient will have no astigmatism, which is affecting the quality of the vision that he has. So there are two important things before you do it. You should know exactly a particular lens. Imagine there's a 20.5 diopter lens. If you're putting it, what is the kind of the residual power you're going to have? That's very important. That's only possible when you've done good biomicros, good biometry for about 25 cases and have achieved the results. And your tunnel, you should be, as Dr. Boramani has rightly said, every tunnel has got certain amount of stretch, and it's extremely possible to have no astigmatic change at all before and after surgery. You can plan it in such a way by modifying it, the tunnel configuration.
Okay. Thank you, Dr. MSR. Couple of questions. You said that your tunnels are always rectangle fashion. You don't make the lateral horns, what we all have been taught about. So lateral horn is basically to accommodate the nucleus when we are extracting out of the anterior chamber. But in all your cases, you dissect or bisect the nucleus, so you don't require the lateral horns. Am I right?
Yeah, you are right. I don't do it. But then I increase, if I have to increase, imagine there is a nucleus of about 9 millimeter size, the one Dr. Devashish and showed. There I make, instead of 6, I'll make a 6.5 rectangular or even 7 millimeter rectangular with a longer. I'll have to compromise on the astigmatism that it produces, but you never compromise on the endothelial count. So
but when you make a 7 millimeter rectangle, would you suture it then?
No, there's absolutely no need for it. There's no need to suture any of these wounds. Even 7 millimeter, you can leave it, but I know it'll produce about 0.75, 1 diopter of astigmatism.
Now, what if one wants to deliver the nucleus? One wants to deliver the nucleus with an irrigating vectis. How it is going to be possible without taking a superior rectus? Can you give some inputs on this?
Okay, excellent question. You try to switch over to the temporal incision. See, like if I had to do from superiorly, it's very uncomfortable because there's a huge lid there, there is a speculum there, and you're sitting awkwardly, the forehead is ballooning, and you're working at a disadvantage. Unfortunately, we have learned that way, and now you migrate to the temporal side quickly, immediately. So then there is no brow, there is no forehead, and you'll enjoy the surgery, and you don't have to rotate it, the eye towards the medial canthus. Why you're rotating? Because your brow is coming there. So you need a straight incision, straight instrument, go and reach the anterior chamber. You'll have to bend the eye. So the moment you switch to the temporal side or slightly upper temporal or lower temporal, depending upon the steep axis, this turning of the eye is not necessary. You don't need a superrectus suture at all. I mean, that's
so you prefer excuse me, Dr. Amit. You always prefer a temporal incision, or you go for superior incision as well?
So, having practiced temporal incision for 3-4 years now, it's very difficult for me to do on the superior side.
So very you prefer doing it through temporal incision?
All cases. If it is with the rule astigmatism, it's rare in that age group, then the steep axis is vertical. Then even in those cases, I would assume that certain amount of astigmatism will be there depending upon the patient's profession. I would rather go and put a toric lens. But superior surgery for me at this stage, having done it continuously, temporal side, is more challenging for me. Because I like the eye downwards.
Yeah, in my opinion, even for a superior incision, the superior rectus is a totally unnecessary trauma to the eye, because with the modern speculums now you don't require. I stopped taking superior rectus before the turn of the century. It's totally not necessary. You can always, if you want to take the globe down, you can do with the do it with the
Forceps.
precision forceps. Yeah.
Dr. Devashish,
Dr.
you had a
Devashish.
comment.
You just need a good corneal forceps, a 2-in-1, 0.2, 2-in-1
Correct.
forceps of good quality, and you can actually play with it, and it actually acts as a second instrument when you try with the vectis, as Amit was asking. What do you do with the vectis? Like when you need to build the internal hydrostatics, so you need to oppose the wound, so you need to bring it a little down. Now when you are bringing the nucleus out, you need to depress the posterior lip. So I mean, this it is a twine like this. So it's the left hand and the right hand plays the other way around. So I think the forceps does excellently. You don't need the superior rectus.
One thing is
Thank
there
you,
in my
everybody.
mind. Can I ask this thing, Dr. Amit? Because I've seen many surgeons elsewhere, they are using AC maintainer for their head, for their additional head, so that to prolapse the nucleus and to protect the incision scleral tunnel. So how do you say, because I've not seen anybody using AC maintainer.
No, AC maintainers are perfect. Yeah, AC maintainers and Blumenthal technique is perhaps one of the best ways of doing SICS.
I use in all cases.
You use in all cases.
All cases.
I think Dr. Basin, we at Arvind, we never were exposed to AC maintainer. LV Prasad is always Blumenthal technique. So people who have come out from LV Prasad, they are preferring AC maintainer.
Proponent of
AC maintainer should be called
we are running short of time. We'll go to our next.
I have one small tip on it. When you are doing it superiorly, one tip is when the patient is lying down, have his chin elevated a little bit. So the forehead goes down and you will be able to reach the upper limbus easily. Just plan it in such a way that just tuck the chin up, and the forehead should be lower than the chin level by adjusting the pillow.
Yeah, very nice tip, Dr. Ramesh sir. So we go with the next talk, that is MSICS in difficult situation by our star international speaker, Dr. Professor Mohammad Mizanur Rahman from Bangladesh. He is professor and head of department of ophthalmology in Bangladesh Medical College. He is the president of ISMSICS Bangladesh chapter. He is also the president of Bangladesh Glaucoma Society. Just a couple of days back, we had a webinar of so-called SARC glaucoma webinar, wherein Dr. Mizanur was there, and he showed great skills in his glaucoma surgery in combined SICS and trap surgeries. So that was the time when I was introduced to him, and I was mesmerized with the way he demonstrated his video surgical skills. So over to you, Dr. Rahman, for your presentation.
Thank you, Dr. Amit. Am I audible to everybody?
You are audible.
Good evening to everybody, and I must grateful to MP chapter, ISMSICS, and organizer, especially Dr. J. Brahmani, Dr. Purendra Bashin, and Dr. Amit Parwal for inviting me as the speakers. And I must welcome you all on behalf of ISMS Bangladesh chapter and our president, chairman, Professor Abha Hussain. Just I want to show some videos of SICS in difficult situation. In difficult situation, why we are doing SICS, that I want to show. So these are the situations: black cataract, capsular fibrosis, combined procedure, and the conversion from the difficult facus, dislocated or subluxated lens, and scleral fixation IOL. So this is a black cataract. This is a very distressful and very stressful condition for the surgeons, and especially it's a grade 4 cataract and very hard cataract. And phacoemulsification is very difficult in this case because of stickiness and its hardness. Because breaking of the nucleus and the emulsification is very difficult. In that case, there is chance of rupture of the posterior capsule, endothelial decompensation, and the nucleus may drop down within the vitreous. So we have the option to remove the nucleus, control of the nucleus only by the small incision cataract surgery. And in this situation, Dr. Devashish Bhattacharya nicely shown how to manage the black cataract. I usually prefer the can opener method of capsulotomy and sometimes I do. This is a very big, you see the large and very black cataract. So next, another very problem is the capsular fibrosis. You see the capsule, this is a fibrotic capsule, calcified, and capsule is attached to the anterior surface of the lens, and the cataract is also very hard cataract. In this situation, rhexis is very difficult. Sometimes you need to excise the capsule by the Vanna scissor, and I always prefer to give the incision in the 12 o'clock position. This is the incision, and I have given a large incision in the 12 o'clock position. And I have removed the nucleus with the baked teeth, and you see the cortical matter, that is also very hard cortical matters. The next another problem is SICS in small people. Small people is very problem if the cataract is very hard, and in this situation phaco is very difficult. Sometimes we can do the phaco emulsification by pupil expander or the iris hook, but sometimes the iris hook or the expander may not be available, or the surgeon may not expert with the pupil expander. In this case, I have done the rhexis, and the rhexis is little bit behind the iris. You see the rhexis I have done a little bit behind the iris, and the cataract is also very hard cataract. Now the rhexis is almost complete. Then rotating of the nucleus, rotated the nucleus in the anterior chamber. One thing is very important in the small people is that engagement of the nucleus. Sometimes it may entrap the iris, and there is chance of iridodialysis. So the anterior part of the vectis should be visible in the anterior chamber. The next thing is the scleral fixation IOL. It's a aphakic case and vitreous in the anterior chamber, and the vitreous tag is stained with the triamcinolone, and the anterior vitrectomy and scleral fixation IOL, that is can also be done through this scleral incision by small incision cataract surgery. One thing I want to mention that by the small incision cataract surgery, we can do all types of surgery, especially all types of complicated surgery. Second thing is the combined operation. Sometimes we need trabeculectomy with small incision cataract surgery. And this is a triangular scleral flap I have done in the 12 o'clock position. And the scleral tunnel is done through the same port. The tunnel is enlarged, and the nucleus is rotated in the anterior chamber, and that nucleus is easily removed through the same scleral tunnel, and trabeculectomy can be completed. Lastly, conversion from phaco. Sometimes we need to conversion. This patient started phaco, but the thickness of the nucleus is more, and the interlenticular pressure was high, and the rhexis was very difficult. The rhexis radially moves towards the under the iris, and as the nucleus is hard, the breaking of the nucleus was difficult. In this situation, there was no option other than the conversion. So this case complete by ISMSICS. This is the rotation of the nucleus in the anterior chamber, and the nucleus is easily removed through the scleral tunnel. So these are the few examples that I have shown where we can do SICS comfortably in the difficult situations. Now the take-home message I want to see, we can do the SICS in all cases, especially we need to do in the difficult case. And it is very, very friendly for the cataract surgeon. And today you have seen that SICS, not only the simple SICS, now the SICS, the beauty of SICS increases with modern technology. And in the CCC conference, I have shown that Dr. Amulya Shah have shown the software guided SICS, artificial intelligence SICS, and today you have seen the premium IOL, astigmatism control, and the others modern technique of the SICS we have shown in this situation. So lastly, I can say we must learn the SICS. We should do SICS, and we advise for SICS and hope for the best SICS. Before thank you, I want to say a few words. Again, I must be grateful to the organizers, and I wish and I hope that the journey of ISMSICS Madhya Pradesh will be successful. And again, I give thanks to everybody. And tomorrow is our Eid. I must give Eid Mubarak to everybody. Thank you very much. Wish you a safe stay. Thank you, Paul.
Wish
Thank
you
you,
the
Dr.
same.
Mizanur. Wish you the same.
In advance.
And we are running late, so we're running short of time. I take one final question, Dr. Mizanur. Nicely demonstrate
Yes.
all the various difficult situations, good quality of videos, and we have already discussed everything. So last one question to all the panelists and the speakers who are present here. Does anybody have an experience with the use of Malukin ring, iris expander, or a BHEX in SICS in small pupil? Among the speakers and the panelists, if anybody has an experience with these, please give your comments. One of these equipments, Malukin ring, BX, or an iris expander.
Pupil, any kind of pupil expander.
Amit,
Other than iris hooks.
No,
Other than iris hooks.
No, these are pupil expanders.
yeah, Amit,
Yes, sir. Yeah, Dr. Devashish, tell me.
because this is an exocapsular technique, right? So, I mean, the moment you use the pupil expander, do the rexis, and before prolapsing the nucleus, you have to take the expander out. So, I mean, it makes no sense. So,
Dr. Rakesh,
Rakesh had to add something.
Dr. Rakesh.
Yes, sir, you can use the expander. Mainly the iris hook is very important to use in the SICS. When put the 4 iris hook in the 4 quadrant, so the when during the delivery, 2 iris hook near the tunnel.
Rakesh, the question is very specific. Does anybody has any experience with the pupil expansion devices other than iris hooks?
No.
That's the beauty. The reason I'm asking you is that's the beauty of SICS. Even with a 4 or 5 millimeter pupil, without using these expansion devices which we use in FACO, we can deliver the nucleus into the anterior chamber in SICS technique and go away with the surgery. The reason to ask this question was this only.
This is more forgiving technique.
SICS is a very beautiful, it's art and craft and less of science. Science also is there, but it's art and craft, as Dr. Rahul said. And we don't need any of these fancy equipments. With our own skills, we can handle any type of cataract with this technique.
One comment.
There is no IFIS in SICS.
One more comment. See, we are using pupil expander in SICS. One more pupil expander, that is the nucleus.
Nucleus itself is a pupil expander. So with
Dr.
this,
Rakesh, I think Amit, I should give time to Dr. Rakesh because he is a wizard of SICS and he is a wizard of SICS, I should say, and he does a lot of trap with SICS and many other surgeries. So Rakesh, please share your experience. 1 minute.
Sir, we can use the pupil expander like the rings, like BXA ring, but it can help only during the rexis part. So the before after the rexis, you can remove the ring and then prolapse the nucleus in the anterior chamber. Because when the pupil is flexible, then you can prolapse it very easily.
Anything else you want to add, like with trap with SICS or anything which you do special, which you can do, and which you have all witnessed other surgeries?
Yeah.
You have witnessed a lot of surgeries here in this panorama of surgeries in this webinar. Anything you want to add to it? Rakesh, your personal experience.
Sir, SICS is actually in the combined surgery. You can do very easily, but you can make the triangle flap and then you can make a curve incision. So you can deliver the nucleus very easily and do the trap surgery in the same port.
Thank you. Thank you. Dr. Shashi, you want to say something?
You have to unmute yourself, Dr. Shashi. Unmute yourself.
Dr. Sumarti,
all things is very complaint, and in SICS it is true. The pupil itself is expander. When we deliver the nucleus, so pupil flexibility of the pupil is stretched. and it deliver the nucleus because we are doing SICS in the NDI chamber. So there is no need of expander while doing the SICS in small people.
We
Dr.
take last one
Sumarthi,
comment from Dr. Sujata.
Sumarthi.
Yes, for me, if small pupil is okay for to take the nucleus into the anterior chamber, but the problem is not there actually. When pupil is already small, then how you do the rexis? You can't see its well, right? If your rexis is quite wide and then can do properly rexis, then it's no problem to bring it with the small pupil with the Sinsky, and you just like art to bring it into the anterior chamber. But the problem, the CCC or rexis is very important. How to do that? Yeah.
Dr. Sujata.
We take one last comment from you. Dr. Sujata, please unmute yourself.
Good evening, everybody. This has been a very interesting session. I would have just said what Madam Shashi Jain, she took my words actually. I was just going to say the same thing, that in SICS, the pupil itself doesn't need anything to be expanded. It works by itself. That is just what I wanted to say, but it has been an amazing experience sharing all these, getting to a chance to see all these interesting videos. Very, very nice. Thank you so much. ISMSICS for this.
Thank you.
Dr.
Now
Amit, can I
we go
just
ahead
add,
with our next. Yeah, Dr.
Can you just add one point?
Yeah.
See, we have to keep all these expanders in the OT, but I'm just waiting for a day I can use them. So far, there was never a need for
same over here.
And second one is not only that, even endocapsular has no role in SICS.
Yeah.
I've never used endocapsular ring. We have all kinds of all sizes of them. They get expired, but there's no need for it.
That's true. Now we take one last comment from Dr. Tiwari, and then we shift the podium to the Secretary ISMSICS, Dr. Srinivas Joshi, to take the proceedings further. We are already running late of time. So the last comment by Dr. Tiwari of 30 seconds. Yeah.
Right. I would just like to say at the end that
it is not over
an
yet.
SICS surgeon may not necessarily learn phaco because of these peculiar situations. I'm aging now, I'm 62 or 63, I don't want to learn phaco, okay. But a phaco surgeon must learn SICS because it will.
Okay, thank you, Dr. Tiwari. So, Srinivas Joshi, Secretary of
Thank you, Tiwari sir. I think,
India.
See, the baby steps of everybody's career starts with SICS. Whether you do phaco or whether you do phaco knit, or whether whatever procedure comes into the future, or the femto or whatever it is, but the baby steps of each and everybody's career, in India at least, I think it starts with SICS. So I think that's how we have so many proud members of this ever-loving ISMSICS society. So without wasting much time, we'll quickly start the installation ceremony. We hope to finish it within 10 minutes, and I'm sure by 9:15 you all will be for your dinner with your family. I promise that. So quickly, I'll start my screen share. Yeah, once again, good evening, everyone. On behalf of ISMSICS Society, I welcome you all. And I would like Dr. Sahu sir to please say a few words before we start up.
Well, this is the SICS is the global phenomena now, and India is the powerhouse of SICS, and we have stuck to our guns. Because I will just share an anecdote. When I visited Egypt, the professor told me, my wife is shouting at me all the time that now you have taken a new machine and now you are again asking for another machine. So when are you going to save the money? So that is, we have been serving the machine for a very long time. Now it is time has come for us to serve the surgeon, and surgeon should come to the center, not the machine. When you are telling your patient, I have this machine and that machine, you are reducing yourself to nothing. So now you say, I'm the best in the field. You don't tell me what I'm supposed to do. You want a good eyesight, I promise you good eyesight. Forget about my method. I can do magic with my hands, or I can do my machine whenever I have got a new machine waiting in my home thing. I don't know when to use it, you know. So that machine is, my son was asking why you invested so much of money. I said, what can I do? I'm getting good results, so I'll let me see whenever I feel I can use it sometimes. But now this is the situation. So there's those who want to be a master, they should know everything. But those who want to practice, they need not have a compulsion of going for a big machine. Master means I have everything. I want to do whatever I want, whenever I want. So that is what I am saying, that new surgeons should decide either they become perfect. Like you see this MS Ravindra, he is a highly trained peco surgeon, vitreoretinal surgeon, and now he stuck to his guns. So he remained SICS surgeon throughout. Buramani is also a peco surgeon. He stuck to his guns. So it requires a little bit of conviction, of courage of conviction to say, I am an accomplished surgeon. Bas, finish. Then you master the phaco and you master everything. That much I want to say. There is, earlier they were sighing that saying I'm a SICS surgeon. There is no sigh involved anymore. It is a pride, because everywhere they will like to learn from you how to do SICS. I have given instruction course in ASARS and other places. They were saying how you are doing it, how this incision is doing, how you bring out the nucleus. They are in that stage. There is a mental block. So we have to come out of that thing and tell them that, look, this is an art and you must learn. Okay, with that I want all of you to feel proud as SICS surgeon. Thank you.
Thank you, sir. As you all know, Dr. Sahu sir is the founder chairman of ISMSICS Society, and it's growing worldwide with more and more many countries joining us. So I would now request our present chairman of ISMSICS Society, Dr. Boramani sir, to quickly move through the journey of ISMSICS Society.
Yeah, I'll just quickly move through the slides. Thank you, Dr. Srinivas. This is mainly to induce more members and to make the all new people who are new to ISMSICS, make them know what is our society. ISMSICS was formed in 2005 by founder chairman Dr. Amulya Sahu. The main aim was to promote small incision cataract surgery across the globe. Live members today have crossed 1,000, and here I want to mention a special thanks to Dr. Purendra Bhasin and Dr. Satish Premchandani and their entire team to have a massive effort, and within a span of 15 days, they have brought in 225 members within 15 days. This is a record-breaking performance of MP chapter of SICS. The launching was done in Mumbai in a SICS workshop in 2005, and in the same year, our team went to China for an ISMSICS session. In 2007, we had a big conference in Malaysia. In 2008, again, it was in Indonesia. Dr. Sumarti is with us right from the beginning in all our conferences. And this conference mega under in 2009, there were 3 events. One in Egypt, ISMSICS conference, in Sweden, and even in Philippine annual conference, one session was given to ISMSICS. In 2013, we had a big camp as well as SICS training program in DR, South Africa. We had published our 7 issues of our journal when I was editor of ISMSICS. Now this program is going to restart again. In 2015, in APACRS, ISMSICS was invited to conduct a wet lab in SICS. And then we started from 2015 onwards with our biennial world conferences. The first major event was held in Pune, jointly with Pune Medical Society, a 3 days conference. The next was jointly with Arvind Eye Care System in Chennai, again a mega event. Both the conferences, the attendance was almost 800. And in this conference, ISMSICS became a global partner with Help Me See, which is a big NGO worldwide, and they are into manufacturing these SICS simulators. In Barcelona World Congress, the last World Congress, we were given a instruction course as well as a satellite program that was a wet live in Barekar Eye Institute. And in the same institute, Professor Rafael Barekar released our e-book or master guideline of SICS. We had various CME programs all over India and various places. Then ISMSICS symposia were offered in various conferences. And this was a major event again, the 3rd biennial conference in Kolkata, thanks to Dr. Debashish Bhattacharya for his excellent, he conducted this conference excellently. The icing on the cake was that he had given transport to not only to the faculty, but to all delegates. It was a fantastic conference. Then AIOC has been offering Magic of SICS 1 and 2 sessions. These are in the major halls. Right from 2018 onward, they started giving these 2 major sessions for ISMSICS. In the last World Congress, which was virtual, Again, the AIS offered us talks. One AIS session was totally converted into SICS, and our ISM SICS speakers were there in the session. So these are all the forthcoming events. These are announced in the Kolkata conference. Dr. Ampon announced the midterm conference in November 2020 in Bangkok. Professor Jagatram announced the next conference in Chandigarh, and Professor Bonnie Henderson announced the subsequent conference in US. That will be in 2013. We have got the presence in almost all the states of India. This is an old slide. And there is ISMSICS is affiliated to AIS, and we have chapters outside India also, almost in 10 countries. And there are a lot of future plans of ISMSICS, especially training programs, and our secretary will in due course intimate about these plans. These are the launching ceremonies outside India, one in Egypt and one in Bangladesh. And in the COVID pandemic, we had various webinars, and the attendance is massively increasing. The last international webinar was attended by 9,172, and even our state webinars have attendance more than 5,000. Today, I think it has crossed 6,000 again. So I request each and every one of you to become a members. Those who are attending and not members of ISMSICS, you can take the screenshot. This is our website, ismsics.com, and this is a link for the to become a member. This is online membership. Thank you very much.
Thank you, Boramani sir, for that quick presentation. So before moving to the installation ceremony, a quick words of wisdom from our president, Dr. Debashish Bhattacharya, whom I call him as my management guru. You must have seen a spiritual guru, Sadguru, all those gurus, but he's a real management guru. Over to Dr. Debashish sir.
It's been a very pleasant evening, and I would have been very happy if we could have gone to Madhya Pradesh, some city, maybe Indore or maybe Bhopal or maybe some place, and inaugurated this MP chapter. It was so pleasing to hear that within 7 days they could bring in almost 250 new members. Amit, Satish, Mahashabde, Purinder, all of you, all my good friends there, thank you very much. And I know Madhya Pradesh is going to do an excellent job, and under the leadership of the, I understand Sadguru is as in Chitrakoot, as in Madhya Pradesh, under the able leadership of Dr. B.K. Jain, Rakesh Saikia, and the soldiers like them. And all of you, I think MP state is just going to take the lead and go much higher up the ladder and take very active role in this whole movement. Thank you very much. Wish you all the best.
Thank you so much, sir, for those kind words and the blessings which everybody, and especially the more of the states who are getting installed, needs that. So quickly, we'll move on to the last part of this function before the vote of thanks. I would now like to say a few words about the Madhya Pradesh. So in fact, I think Boramani sir and Dr. Debashish sir already spoke about having the highest record number of membership at one go within 15 days. And all thanks to the efforts made by Dr. Purendra Basin, Dr. Satish Premchandani, and Dr. Amit Porwal, Dr. Mita Joshi, and everybody in the team. They created a history in ISMSICS society. So wonderful Madhya Pradesh society. And I would like to call it as the diamond state. So here we are now introducing the diamonds. You know why? The rest of the delegates who are listening to this? Because the Madhya Pradesh has the largest revenues of diamond and copper in India. So here now I would like to introduce these diamonds. First, I would like to install on behalf of ISMSICS society, the chairman, the president, and the founder chairman and all the other society. I would like to call upon Dr. Purendra Basin, the chairman of ISMSICS MP chapter, director Ratan Jyoti Netralaya Gwalior. He finished his fellowship in anterior segment from Arvind Eye Hospital, Madurai, founder and medical director Ratan Jyoti Netralaya, Ophthalmic Institute and Research Gwalior, vice president of Ocular Trauma Society, member managing committee AIOS, from MP, vice chairman Ocular Trauma Society of India, and former chairman. He has received various awards. To name a few, AIOS Rakesh Sharma Best Paper Award in Trauma in 2017, PC Roy Memorial Award, RP Dhanda Memorial Award in 2004, Best Video Awards, various video awards, including the gold medal for his contribution from IIRSI in 2008 and Bombay Ophthalmic Association in 2011. So I now request Sahu sir to please offer him the chairman medal. Here comes it. So though we don't have it on site, but I think the virtual is connecting all of us together. And on behalf of ISMSICS Society, we now present him the bouquet. Welcome, Dr. Purendra Bhasin, sir. A few words, please. You can unmute yourself, sir.
Thank you, Dr. Srinivas, and really thank my team, the teamwork which they have shown, and a special thanks to Dr. Mahesh Somani, who has given a really very nice cooperation to all of us, Dr. Satish Premchandani and all. My real gratitude and thanks to the founder chairman, Dr. Sahu, Dr. Boramani, and chairman, Dr. Devashish, and Dr. M.S. Ravindra, and those who have come from Bangladesh, Indonesia, and all my state members and the members who have, I will definitely love to be with them, Dr. Pradeep Vyas, and work as a team and uplift the society, ISMSICS society in the state of Madhya Pradesh. Thank you.
Thank you, sir. Thank you very much for those kind words. And now we would like to introduce our president of ISMSICS Society. MP chapter is none other than Dr. Satish Premchandani. Dr. Satish, we all know, is a ever-smiling personality, the director, Vision Center Indore, and he has experience, worked as a consultant at REH, and worked as consultant in Shivanand Mission Eye Hospital, various posts held including Vice President of MPSOS, Honorable Secretary, Honorable President of IDOS, Chief Organizing Secretary. This is the conference which none of us can forget it. The wonderful conference of AIOS hosted by the Madhya Pradesh Ophthalmic Society. Who can ever forget that? Thank you, sir, for all those things worked hard. You people worked hard for as a team. Organizing Secretary of MPSOS, Organizing Secretary GSI, and various other accolades. So with this, I now request Boramani sir to please install him with the Presidential Medal. And here comes it. So with this, we welcome Dr. Satish Premchandani to the ISMSICS family. Thank you, sir. Dr. Satish, sir, few words quickly, please.
Thank you, Srinivas. As you are a good friend of mine, and you have been always a source of inspiration to the juniors as well as the seniors. And thanks to Dr. Sahu, thanks to Dr. Boramani and Dr. Devashish, he has always been source of inspiration. And Dr. Pradeep Vyas, of a senior member of MP, and Dr. Purendra Bhasin as a chairman, he was always a motivational force for me to make large number of the members over here. And we promise to go by spell and bounds to reach to the highest number of the membership over here. And ISMICS is a bit cumbersome to speak, so why not give it as a very good name as ISMSICS? It sounds a bit sexy. ISMSICS. So it can be called as ISMSICS. So thanks to the ISMSICS central body, and thanks to all the MP state delegates and the post holders. Thanks a lot.
Thank you, Premchandani sir. I think these two personalities, the chairman and the president, are I would like to call them as Ajata Shatru. I have not seen them having any enemies here. Again, I would like to introduce our next person, Dr. Sudhir sir, the vice president of ISMSICS MP chapter, who is the medical director, Indore Eye Hospital, and Mahashabde Netralaya and Child Care Center is the director of ophthalmology, Index Medical College, Indore. So with this few words on behalf of ISMSICS Society, I welcome Dr. Sudhir Mahasabde sir for the family. Welcome, sir. Few words, Dr. Sudhir sir, quickly. Dr. Sudhir sir, are you there?
Srinivas, he's having some connectivity issues.
Okay.
Okay, fine. We'll move on to the next. Yeah, sure. And now comes the blue-eyed boy in Indian Ophthalmic Society. He is the chairman, scientific committee of is none other than Dr. Amit Porwal, the director of Sangvi Netralaya Belgavi, senior consultant cataract and the head of glaucoma services of Chaitram Netralaya Indore, member scientific committee All India Ophthalmic Society, central zone executive member of Glaucoma Society of India, clinical secretary Indore Divisional Ophthalmic Society, and ex-member of AIOS ARC Central Zone. So here we, on behalf of ISMSICS national team, we would like to welcome Dr. Amit Porwal to be installed as the chairman of scientific committee of ISMSICS MP chapter, and I'm sure that he is going to bring great accolades to the ISMSICS society as a part on the whole, and see it growing more and more. Thank you very much, and welcome Dr. Amit Porwal. Few words quickly, Dr. Porwal, please.
Thank you, Dr. Srinivas. You are a great friend of mine. We belong to the same college, and getting the ISMSICS MP chapter was a dream. In AIS 2019 Indore conference, Dr. Sahu, Dr. Boramani, Dr. Satanshu, Dr. Parikshit, and all the other office bearers of the central committee were there, where we talked about the ISMSICS MP chapter. And I always like to be an academician and like to go ahead with the scientific work. So, being the chairman scientific committee of ISMSICS, just before this webinar, Dr. Boramani and we were discussing. So, I take great privilege and pride to say that in this coming year, at least minimum 3 to 4 ISMSICS webinars I will be conducting with this state chapter, with the leadership of our chairman and our president, Dr. Satish Premchandani, and our chairman, Dr. Basil. So, thank you, Srinivas, for installing me and team ISMSICS.
Thank you very much, Dr. Amit Porwal. And now we have a dynamic secretary of ISMSICS MP chapter, who is none other than Dr. Meeta Joshi, who is the Associate Professor, Community Ophthalmology, School of Excellence for Eye, MGMMC Indore, Joint Secretary, MP State Ophthalmological Society, Treasurer, Indore Divisional Ophthalmological Society, and above all, a great human being and an ever-smiling lady. So with this, on behalf of ISMSICS National Society, I welcome Dr. Meeta Joshi to be installed as the Secretary of the MP chapter. Welcome, Madam. Few words quickly, please.
Yeah, at the outset, I'd like to thank you all for this opportunity and for having the trust and faith in me that in spite of all obligations, my husband is actually admitted with COVID in hospital, and instead of all these, you all trusted me to take these responsibilities and get on with the work and have this event today. So thank you all, and we promise to work for SICS and make it a surgery, bring it out of the narrow viewpoint that it is only a camp surgery. And the videos which we have seen today would definitely help to make SICS a more of a global phenomena, a more of a all type of cases can be done kind of thing with this. Thank you.
Thank you, Madam, for those kind words. And lastly, the Joint Secretary, before installing the executive and the scientific members, we have, again, you see, a smiling personality, prolific surgeon. I've seen him operating in at Disha Eye Care Center. Fantastic surgeon who is none other than Dr. Rakesh Sakya, who is being installed as the Joint Secretary of ISMSICS MP chapter, is a high volume surgeon at Sadguru Netra Chikitsalaya Chitrakoot, senior consultant of cataract and head of glaucoma services. On behalf of ISMSICS National Society, we welcome Dr. Rakesh Sakya to the ISM family.
Thank you, sir. Thank you so
Yes,
much.
Dr. Rakesh, you want to share anything before we move on?
So, sir, today is the OCPS day actually for the MP, and especially I would like to thank to Dr. very dynamic person, Dr. Puren Vasi, and our founder, Dr. Amul Sahu, and Boramani sir, and Bhattacharya sir and MS Ravindra sir and very dynamic person Amit Korwal sir also. So this is our challenge to make this society very powerful in the MP. So this is very thank you, and I give the assurance we do the work very dynamically and make the SICS in the high level, because the SICS is the gift of God, not a small simple surgery. Thank you.
Not a gift of machine, gift of God.
Yeah. Thank you.
Very nice.
Thank you, Dr. Rakesh. And quickly we move on to the next members we have is none other than our pranams to the most experienced and ever-loving Dr. B.K. Jain sir, the most respected ophthalmologist in Indian community. You all know he has brought Chitrakoot to the world level, and he's now the advisor of ISMSICS MP chapter, the director and trustee of Sri Sadguru Seva Sangh Trust, and on behalf of whole ISMSICS society, we welcome and our pranams to Dr. B.K. Jain sir for being an advisor to the MP chapter. Welcome, sir.
Very nice.
And with this, we move on to the next dynamic members of the scientific committee. We have Dr. U.S. Tiwari, Professor and Head of Ophthalmology Department at GR Medical College, Gwalior. Welcome, sir. And then we have Dr. Navneet Saxena, Professor and Head of Ophthalmology, NSCB Medical College, Jabalpur. Welcome to the family, sir. And we just listened to the lady who gave a lot of insights on SICS, Dr. Shashi Jain, who is a professor and head of Sham Shah Medical College, Rewa. Welcome, madam. And with Dr. Pradeep Vyas, senior ophthalmologist from Ujjain, who needs no introduction. Welcome to ISMSICS Society family, sir. And then we have Dr. Parvez Siddiqui, Professor, NSCB Medical College, Jabalpur. Welcome, sir. Welcome to the family. And we have Dr. Mahesh Somani, the Director of Vision Center in Indore. Welcome, sir. Welcome to the society.
Welcome, Mahesh.
Pardon?
No.
Yeah. And then we have Dr. Praveen Khare, Professor, Bundelkhand Medical College, Sagar. Welcome, Dr. Praveen. And then we have Dr. Safi from Modiwala City Eye Hospital, Ujjain. Welcome, Dr. Safi. Welcome to the family, please. And then we have another ever-smiling lady, Dr. Sujata Lakhatia, Associate Professor of Sham Shah Medical College, Rewa. Welcome, madam. And we have Dr. Ashok Solanki, Consultant, Labmuni Eye Hospital, Mandsaur. Welcome, sir. We have Dr. Manbir Singh, Anterior Segment Surgeon, High-Tech Eye Care Hospital and Laser Center, Bhopal. Welcome, Dr. Singh. And we have Dr. Arpit Aaron from Aaron Eye and Dental Hospital, Ujjain. Welcome, Dr. Arpit. So with this, we have installed nearly around 16 diamonds of Indian Ophthalmic Society, and we hope they donate the 16 diamonds to ISMSICS National Society. Purendra sir?
Definitely. We are part of the International Society now, and we'll definitely lead that the road ahead, take the society ahead further. All the diamonds are very, very bright.
Thank you, sir.
They
Thank
are
you very
glittering.
much.
Yeah,
Thank
I
you.
have full faith on them.
Great.
And together
Thank you,
we
sir.
will do good things towards manual small incision cataract surgery. And we have one more idea, as I was discussing with Professor Sahu. With the team, we want to do a video competition of small incision cataract surgery amongst international competition of video competition, 3-minute or 4-minute video. And that will be a prize competition. We'll be giving a cash prize to the winners. We'll do that.
Wonderful, sir.
That
We are
will
definitely with you. Sahu, sir, you are muted. Sahu, sir, you can just unmute yourself.
Please unmute yourself. Sahu, sir.
No, just wanted to
Purinderji, you take this idea forward. We will have a international competition on this.
Thank you, sir. Thank you,
We will
sir.
write to all chapters and you lead it from the
Thank you,
front.
sir. Sir, we and our team will work on that, and we'll
Wonderful.
come out
We
with
are
it.
with you, sir.
Thank
So
you.
Sumati, Indonesia, you get your people ready for a competition.
Okay,
There
sir.
will be a panel to decide which is the
Judges.
best video, and then we will announce the panel, and we will give them prize.
Okay.
That will be an international recognition for them.
Okay, thank you, sir. I will.
Thank you.
Even Dr.
Thank
Miznur.
you.
Dr.
Yes,
Mizru.
Yeah, Professor Mizanur, I think we have a volume, the beautiful surgeons in Bangladesh.
Yes,
They are
yes.
really enthusiastic and doing great job. So we want to, now we are going to have ISMSICS African sort of, webinar, then Bangladesh, with Bangladesh we want to have a webinar. Now Indonesia, then Mexico, then all these things after this state chapter is over, or in between state chapter we want to have this our chapters conference outside. So
Okay.
I want this, if simultaneously we have this video competition, it will bring the young people into the fold and show their skill.
Yes, sir.
Okay, thank you, sir.
Debashish sir, you were telling something, last words?
No. I just wanted to wish Meeta all the best. Her husband is not well. So just wanted to wish that he recovers very quickly. That's it. And yeah, of course, all the best to MPs. And I'm very confident with Satish, Amit, Purinder, and everybody there, they will do a fantastic job. I'm very
They
sure.
have already done a fantastic job. So wish you all the best.
Thank you, sir.
Anybody wants to give a last comment? Dr. Pradeep? Pradeep, sir? Yes, sir.
Yes. First of all, I congratulate to the new team. I would like to share that I am the only person who was president in for 2 times. It's a record. And Purendra, Satish, Mahesh, they have worked with me. Some of them were secretary, vice secretary, and some of them were chairman scientific committee. Now they have made me executive committee member and they know my working. So आप चिंता मत करिए, इस टीम से तो मैं मार के काम करवा लूंगा अच्छा. I'm leading a seat, probably इस समय सबसे सीनियर अभी मैं ही बैठा हूँ, इसलिए अधिकार से बात मैं कह सकता हूँ. Thank you and congratulations again.
Thank you, sir.
Thank you, sir. We'll need all your blessings. Thank you. Anybody wants to give the last comments?
Dr. Professor Tiwari.
Unmute, sir.
Thank you.
Dr. Tiwari, sir.
First of all, I must thank all the stalwarts. I'm really impressed, and I'm sure the society is going to make phenomenal progress under the leadership of the stalwarts like Dr. Sahu, Dr. Srinivas Joshi, Dr. Boramani, and the others. A really wonderful society. And I'm sure that the leadership, Dr. Purendra Vasin, Dr. Satish, and others, we are going to make a phenomenal progress. It's the Madhya Pradesh state also, and thanks everybody. Yeah.
Yes, Satish bhai, go ahead.
Yeah. First of all, great thanks to Dr. M.S. Ravindra. He came in Indore in 1995 or 96 to deliver his lecture on ISMSICS or small incision cataract surgery. And he has been a big motivational force all over the country as well as abroad for this small incision cataract surgery. I have watched him doing that surgery and he is going great and greater day by day. Thank you.
Very nice.
Thank you.
Thank you, sir. I
add one sentence.
Yes, Mahesh, sir. Go ahead, please.
Nothing. Congratulations to the team. Nothing.
Yeah, great. Thank you. And I think everybody has given their words of wisdom and inputs and insights. So with this, we come to the end of this installation chapter. Thank you. Thank you very much, MP
Srinivas.
chapter, and we welcome you all. And we look forward to more and more great webinars of more interest. It's not should be a normal webinar, but it should be an exclusive webinar. And I'm sure with 16 diamonds we have it in our ISMSICS society, definitely you will make our ISMSICS National Society to shine like a diamond. And I'm sure that you people will make it. Thank you very much. Over to the local MPSSAS society, please. Thank you very much.
Thank you, Srinivas. As every meeting comes to an end, it was a great meeting. But before we end it, we would like to give a vote of thanks. And I request our dynamic secretary, Dr. Meeta Joshi, to give a vote of thanks after the installation of this ISMSICS MP chapter. Meeta, over to you.
Thank you, Amit. At the outset, I would like to thank all the members of MP chapter of ISMSICS for their overwhelming response to our membership drive. It would not have been possible without the great response which they have given us. Thank you all the office bearers, Dr. Sahu, Dr. Buramani, Dr. Gogate, Dr. Sitanshu, Dr. Ravindra, Dr. Debashish, and Dr. Srinivas. Thank you all the speakers for the wonderful videos which were there. Each video was like a not to be missed kind of event. And all the panelists for the inputs which they have given. Thank you, Dr. Sumarti and Dr. Professor Rahman for making this a truly international event. And thank you, Edward, for all the groundwork. At the end of it, thank you all again for making this a stupendous. Thank you.
Thank you.
I think we should thank
Dr. Sahu,
and I must thank
Mr. Raman and
from side of
Nikhil
all of us,
Asulkar.
special thanks to Dr. Amit Porwal.
Yes.
Thank you,
Dr. Amit Porwal for conducting the session so very well. Congratulations.
Thank you very much. Thank you.
Thank you.
Everyone, thank you, Entor. Thank you, Raman. Thank you, Nikhil, for
Thank you.
always being the torchbearer of all these ISMSICS
all
webinars.
these programs.
Thanks, Dr. Sujata. Thanks, Dr. Shashi.
Thank you
Srinivas.
Thank you so much. It has been a privilege being part of this esteemed society, and I hope we'll do very well and bring MP to the forefront of this society.
You have to
Once this COVID thing is over,
They have stopped
I'm sure
recording.
that
I think we can go off record also. No problem.
So Srinivas, that's what. Srinivas,
Yes.
Dr. Sahu, Dr. Boramani, a small request. See, within a 7 days span of time, a membership of such a great number by MP chapter is record breaking. And I think that should be an example for all the other state chapters and a motivational force. We should identify those people who can be a motivational force to increase our membership drive. And we should set it as an example to all other state chapters that we have to